Hello everyone. Hope you are doing well and are safe in whichever part of the world you are. I am Dr. Aditya Joshipura and I am a surgical oncologist at HCG Cancer Center Ahmedabad and I am your host today. On the behalf of Oncosurgery Master Course 6, I welcome you all. Now in the era of webinars left, right and center, we got the impression that the audience wanted more than just mundane transfer of theoretical topics. Hence, in keeping up with the tradition of novelty that Oncosurgery Master Course is famed for every year, in our sixth edition, we have decided to tread the lesser known path of complications in head and neck oncology. And we have been blessed to have over 1,000 registrations from all across India, Pakistan, Nepal, Iran, Afghanistan, Sri Lanka, Indonesia, Bali, Nigeria, Kenya, England, Portugal, Australia, USA, Mauritius, Canada, Qatar, Zambia, South Africa, Jamaica. This has been made possible by the committed efforts of the Team Extraordinaire. Introducing to you Team OM 6. Oncosurgery Master Course series was started 6 years ago by the vision and efforts of Dr. Kaustubh Patel and Dr. Rajendra Toprani, and they are the beacons whose light shines bright over the event as their organizing chairman. The brains that conceptualized the event are the course directors Dr. Dushyant Mandlik and Dr. Dakshesh Patel. The tireless work ethic and micromanagement displayed by my fellow organizing secretary, Dr. Pareen Patel. The core of the event, our wonderful scientific committee, Dr. Purvi Patel, Dr. Nitin Sharma, Dr. Dhanusha Goyal, Dr. Ashay Shah, and Dr. Mitesh Patel. Design, conceptualization, and coordination, we thank Dr. Sanjeev Dhawan, the man of ideas from Ahmedabad Cancer Foundation. Now, coming to the rules of engagement, in order to conduct a sane session where the views of dignitaries are heard, the attendees will be muted. All the questions are to be posted on group chat, out of which the relevant ones will be forwarded to the speaker or the moderator of the session, time permitting. There will be 2 lectures by senior faculties, which will be followed by an expert discussion moderated by a master. There will be ample time given for entertaining audience questions, so we exhort the audience to show some patience. This is a series lasting 6 Saturdays, taking up one specialty of head and neck every Saturday, out of which today is the first episode. And what an episode it is! Today we'll be dealing with the complications associated with the surgery that requires extreme skill and has excellent prognosis if done well, mandating the need to give a trouble-free course of treatment to the patient. Hence, the question of what if there are testing times for finesse and function. To open our innings, we have arguably the best Indian batsman in the world as recognized by the UICC itself. Dr. Anil D. Cruz, the most household name in head and neck oncology in India, has served as an oncologist, director, researcher, administrator, and crusader for over 30 years at Tata Memorial Hospital, Mumbai, and now Apollo Hospitals. He is the president-elect of the prestigious UICC. He has been actively involved in the formulation of international guidelines and has over 200 peer-reviewed publications to his name. He will be enlightening us on the parathyroid issues in thyroid surgeries, a much dreaded complication that can leave even the most experienced surgeon stunned. We are delighted to kick off our OM 6 in a grand style. Over to you, Dr. Anil D. Cruz. Sir, can you unmute your mic,
Anil, you
please?
need to unmute.
Yeah. Okay. I don't know why it's not sharing. It just worked. Holy hell, I'm not able to share this post. There it goes. Okay. Lovely. So thank you, Aditya, for those very, very kind words. Thank you, Kaustubh and Rajendra, for a chance again to be part of OM. I've been part of every OM that has been done, except I think the first when my mother was unwell. But it's always been a pleasure. What I'll really miss today is the evening banquet that is so elegantly done in Gujarat, smuggling in the whiskey when it's not permitted. And I'm going to miss that, but the science I'm going to enjoy as well. And also, you've asked me to speak on something very dear to my heart, and that's thyroid surgeries. I've tried to make it as practical as possible. So those of you all who have logged in and want talks on autofluorescence and indocyanine green, You can log off and go grab an early beer and come back for Claudio's talk 15 minutes later. I'm going to be very practical, share some of my experience, some part of theory on how we save the parathyroids in thyroid surgery. Here is a hot off the press review, which I think every resident or even faculty should get. This is April 2020 JLO Journal, Predictors of Post-Thyroidectomy Hypocalcemia, a systematic review and a great narrative. They've looked at 63 studies, over 200,000 patients, a 7-year time span. The incidence of transient hypocalcemia is 27.5%, which ranges from 3.2 to 82.6. Symptomatic median is 12.5, ranging from 0 to 50%. And permanent ranges from 0 to 14.5 with a median of 2.2, telling us that hypocalcemia is the number one complication following thyroidectomy. I've tried to be a little fancy and put those numbers into statistical, and it's called a box and whisker chart. I just love this name. And that's why I said, let me try be a little fancy. And I put this up. And just to put this in pictorial form, look at transient biochemical changes, 3.2% all the way up to 80, 81, 82%. That's the whisker. These little box are the interquartile ranges. The line signifies the median and the ball signifies the mean. So it's 27.5%, symptomatic is 12.5%, and permanent is 2.2%, just to tell you the enormity of the problem. Further, in this 63 studies, they have looked at 45 separate predictors for hypocalcemia. Predictors for hypocalcemia could be biochemical, that's pre-op levels, post-op levels. They could be surgical factors, which could be a total thyroid, completion thyroidectomy, surgery for Graves. They could be patient factors that are gender, age, bariatric surgery, and miscellaneous. People have also looked at the season. Apparently, you get more hypocalcemia if you operate in winter as compared to the spring. 30 of these predictors statistically significant effect on post-operative hypocalcemia in at least one study. I have 15 minutes. If I do 30, I'll have 30 seconds for each. So as I told you, I'm just going to be very, very practical and touch on some of these predictors if relevant in our day-to-day practice. And here's how I'm going to do my talk. 5 subheading. First, prevention of parathyroid injury at surgery. Second is intraoperative detection of the damage of the parathyroids if you've caused it. Then intraoperative salvage of the parathyroids. The fourth will be post-operative detection of hypocalcemia and correction. And I'm not going to tell you about how to give calcium. And the last will be some recent advances on the implications of long-term hypoparathyroidism and methods that are now described to correct these. So we'll go to the first, prevention of parathyroid injury at surgery. Now here's a diagram that I've taken from Greg Randolph's book, and this everybody knows, but I know there are a lot of juniors. Superior parathyroids have a smaller area of dispersal, more easily to locate. They don't roam all over the place, develop from the fourth pharyngeal pouch. The inferior parathyroids can be all over the place, as seen by this black line, and a little more difficult to locate. And this is important to keep in mind when you go about locating the parathyroid. But what's very, very important, and again, this is from Greg Randolph's book, is that the parathyroids have a very definite relationship to the recurrent laryngeal nerve. The inferior parathyroids are always ventral, that is above the recurrent, and the superior is always dorsal, that is behind the recurrent. So if you see a parathyroid somewhere up here, which is above the recurrent, it means that it is the inferior. Look out for the superior somewhere in the usual vicinity. And that's the right way to know how to locate your parathyroids. The superior also has a relationship to the ZT or tubercle of Zuckerhandl, but I've kind of modified this diagram with my own thing, and I call it the circle of one. So if you draw a 1 centimeter circle in relationship to the inferior pole of the thyroid, or you draw 1 centimeter circle in relationship to the inferior cornu of the thyroid cartilage, you will see the parathyroids within this 1 centimeter circle in 80% of patients. And I call this the circle of one. For youngsters, please remember this. You can identify the parathyroids by their appearance, the color, firmness, the shape, whether they have a discrete sliding movement or no, and whether there's a vascular hilum or subcapsular vessels. So let's look at the parathyroid. It's tan to brown in color. It's soft. It's elliptical or kidney shaped. It can have 8 different shapes, but these are the most common. When you press on the parathyroid, particularly the superior parathyroid in the surrounding tissue, it kind of glides or slides, and that's called the rowing sign. But the foolproof method is to see subcapsular vessels or a hilum telling you that this is not thyroid, it's not fat, it's not the lymph node, or it's not the thymus. I'm not going to waste time on the other attributes of the other 4 differentials, but again, this is adapted from Greg Randolph's book, and youngsters can just go and take this table from there. Second, when you do a thyroidectomy, and again, this is something that most people would know, but again, for the youngsters, is to do capsular dissection. As I say, to be a good thyroid surgeon, you should learn to hug well. And I don't mean it literally, but I mean it figuratively when you do thyroid surgery. You do division of the tertiary branches of the vessels, and here is a schematic representation to show you how capsular dissection saves the blood supply to the parathyroid, which usually comes from the branch of the inferior thyroid. Please remember that the inferior thyroid artery, the parathyroid, the superior parathyroid, and even the inferior may get sometime branches from the superior thyroid artery. It's classically described as the Halsted and Evans artery. And sometimes you would have this abnormal artery coming from top. So till you do not locate that artery, please don't bunch ligate the superior thyroid artery as well. But the secret is to do capsular dissection. When I trained, people did truncal ligation because they believed the recurrent laryngeal nerve would be safe. And here is a meta-analysis from Louis Kowalski's group, and there are many randomized trials even after this 2017 publication, looking at 1940 patients, 11 non-randomized and 9 RCTs. Look at the risk of problems: biochemical hypocalcemia and symptomatic short-term hypocalcemia were affected if you did truncal ligation, a 6% difference with statistical significance. But if you did definite permanent hypocalcemia, it was 0% in the whole group. No difference if you did truncal ligation. And this is from 11 non-randomized and 9 randomized. Of course, these are small number of patients, different time points, endpoints are different. But just to tell you that vascularity is important, but you should not, as we go along, denude the parathyroid totally. If it stays within its own covering, there is a 0% chance of permanent hypocalcemia. The fourth thing at surgery, and this is something that I always do, and I call it the parathyroid marker. So here's a photograph of a patient that I'm operating. Here is the thyroid up. You can see the parathyroid very well. I dissect the tissue capsularly between the thyroid and the parathyroid, and my assistant drives a clip across. So now look at the clips in the operative bed. I can see the inferior parathyroid here. I can see the superior parathyroid here. Now, when I do my neck dissection, I have no problem at all. I always have the parathyroid under vision. Please remember, blood supply comes laterally from the inferior thyroid artery. So flip your parathyroids towards the carotid and work medial to your parathyroid to save it. But putting a parathyroid marker is very useful to avoid damage to the parathyroid. Sometimes when you're doing a long surgery, you just get so tired at the end and then you forget where the parathyroid is and you might damage the parathyroid. Now, many people and literatures replete with publications on magnification, looking at various harmonic devices for hemostasis, as well as various optical technologies to save the parathyroid, because the parathyroid has its own autofluorescence and it shows up better than the thyroid. Suffice to say, there's no compelling evidence to show that magnification, whether you use harmonic focus, or conventional hemostasis, or you use optical technologies, have robust evidence to recommend them as standard into your treatment or into your operative algorithm. There is some advantage in terms of transient hypocalcemia and things like that, but really the evidence is not robust. And when you read all these meta-analyses, they end by saying that you should have more randomized trial to establish the place of these ancillary methods in saving the parathyroid. We move to intraoperative detection of parathyroid damage and the dusky parathyroid. So here is the same case that I've saved the parathyroid. As I develop the dissection, I look back at my clips and I see a little bit of dusky change in the parathyroid. Now, discoloration usually can be identified by an experienced surgeon, and he or she will be able to tell you whether this parathyroid is going to be dysfunctional or not. But there is a maneuver described by Delbridge. It's called the knife test, where the capsule is slightly incised. And if you can see a little bit of back bleeding, you know probably this parathyroid will live and you don't have to auto-implant it. I just use a 25 gauge needle or a 24 gauge needle and prick the capsule of the parathyroid and see the back bleeding. But I didn't put it up to use a prick test. Sounds a little unparliamentary, and I just thought Delbridge or knife test would be much better than. But for youngsters, just take a 24 gauge needle, poke the dusky parathyroid, you get a nice good back bleed. This would suffice. So you can put a nice warm mop there, go on with the rest of your dissection, and you'll see the color return by the end of your surgery. The other thing at surgery is the incidental parathyroidectomy. It's usually the incidence can vary as high as 17 to 20%. It could be extrathyroidal. That means you have a thyroid in an aberrant position, usually high up on the thyroid. It's usually the inferior. It could be away from the thyroid, mixed within the central compartment nodes. It could be intracapsular, just beneath the capsule, and usually this is again seen with the inferior, or it could be intrathyroidal. Now, intrathyroidal, you'll never be able to find out, and it's relatively rare. So if you don't see the parathyroids, please look at the specimen very carefully. Put your assistant to sit down, look at the specimen, dissect it. 9 times out of 10, you'll find the parathyroid among the tissue or within the capsule of the thyroid, and you can salvage that parathyroid. Some people assess whether the parathyroid is functioning looking at intra-op PTH levels. Intra-op and Brzezinski's classical paper on this, and many others have done it subsequently. They look at PTH levels 10 to 20 minutes after total thyroidectomy prior to closure of your wound. If your PTH levels are less than 10 and you have got the parathyroids in situ, probably they're not going to function. And he advocates that you go and auto-implant this. The cost of the test is $35 US at the time of publication. $50 at the time of 8 to 10 minutes, you get the test results and you can save permanent hypoparathyroidism. Third, intraoperative salvage of the parathyroids. What do you do for that? Now, the parathyroid that is out, that you've got from the specimen, or you've done an inadvertent incidental parathyroidectomy, you have to confirm whether it's a parathyroid. So you can either do a frozen section, take a sliver about 1/8 or 1/3 of the parathyroid. You can do the float and sink method. That means drop it into a bowl of saline. If it floats, it's fat. If it sinks, it's probably parathyroid. But usually the experience of a good surgeon is good enough to tell you whether it's a parathyroid or no. And sometimes when I don't have frozen section, I use my experience judgment. And there's also literature to back this, viewpoint, that if it is a benign condition and you're sure it's not a metastatic node, you need not do a frozen section. But those of you all who are blessed with a frozen section can do it. But the negative of the frozen is that you're now going to lose a part of parathyroid tissue into the pathology department, which would be more important to prevent hypocalcemia if you went ahead and just implanted it. So those of you all with experience, you're sure it's a parathyroid, it comes out by mistake, go ahead and implant the entire parathyroid. You do it by two methods. One's the mincing methods, classically described by Samuel Wells. Lahey described it 50 years before Wells, and then Wells repopularized it 50 years later. So you put your parathyroid in cold saline at 4 degrees of tissue culture. It becomes firm. 30 minutes later, you can mince it well. I see a lot of people taking a kidney tray and just mincing a soft parathyroid. It doesn't mince too well. And then put it into pockets of muscle, and the incision is closed with non-absorbable sutures. You can also do a suspension where you take 1-2 ml of sterile physiological salt solution and you mince the parathyroid with fine scissors, and you can fragment it and then inject it. I usually inject or implant onto the contralateral side at the midpoint, and I'll tell you why. Injection is never done for familial conditions where you may need to go back and take out a functioning auto transplant. Where do you do it? Always at the midpoint on the contralateral side. And this is my philosophy, because the blood supply to the sternocleidomastoid is best on that side as opposed to the side that had the neck dissection. You do it in the forearm of the non-dominant hand in hyperparathyroidism due to familial condition or Men's syndrome. Recently, there's a very good publication by Curvalo et al. Saying that there's a 90% success in the subcutaneous tissue of the forearm. And you do it as soon as possible. And this is another tip for the youngsters. You usually lose a parathyroid, you put it in a little kidney tray and you keep it on the nurse's trolley till the end of your big marathon, bilateral neck dissection, central compartment total. So you've got the parathyroid out at 11 in the morning and you're auto planting it at 6 in the evening, it doesn't work. So the moment you've done that side of the neck dissection, I go ahead and auto implant. Some people do cryopreservation, but cryopreservation is not there for routine thyroid surgery. We probably do it more for familial conditions of the parathyroid. Aditya, how am I doing with time? I've got another 5-6 slides. Is that okay?
Completely fine, sir. Completely fine.
Okay. So now, permanent hypoparathyroidism, it's very, very important. And that's why the parathyroids, there's a distinct discordance between surgeons and patients' perceptions on quality of life. Surgeons underestimate the impact of treatment-related morbidities of hypoparathyroidism compared to the physicians. If you are hypoparathyroid permanently, there's a risk of calcification of renal and basal ganglia. It predisposes to neuropsychiatric diseases, including depressions and infections. But most importantly, there's an increased likelihood of death. And this is shown very convincingly from the Scandinavian registry, something that's recently published in the British Journal of Surgery. So permanent hypoparathyroidism has to be avoided. So people started taking the parathyroids, because even if you saved them, they didn't function in 2.2% of people, and doing elective auto transplantation. Now, here is a snapshot of all patients who had an auto transplant electively as opposed to no auto transplant. And we are looking at the impact on transient hypokalemia and on permanent hypocalcemia. Two studies show that if you electively auto-transplant, there is a 0% incidence of permanent hyperparathyroidism. And that's why this auto-transplant became very popular, but it's not borne out in other studies. If you do auto-transplantation electively, the incidence of transient hypocalcemia is much, much higher as opposed to no auto-transplant. So the rationale of routine auto-transplantation was to prevent a 0% permanent hypocalcemia, but was not borne out by other studies. What is my take on auto-transplantation? If you read literature, Song study tells you that one parathyroid is enough. If you look at Henning Drale's series, 5,000 odd, 2 parathyroids are enough. Delbridge said that even if you leave back 3 parathyroids, sometimes you get permanent hypoparathyroidism. And Zedinis said in 100 cases when he did auto-transplantation, and the 2 series I showed you in my previous slide, there was no case of permanent hypoparathyroidism. So what's my take on this and what message do I give you? Whenever you're in doubt, take out the most dusky parathyroid and auto-transplant it. So you have safeguarded one parathyroid. You will have a higher incidence of temporary parathyroidism, but your permanent hypoparathyroidism will be avoided. So your threshold to auto-transplant a gland should be low. But if you've got all 4 looking pretty good, then I do not recommend routine auto-transplantation. Now we'll go to the next, which is post-operative detection of hypocalcemia and its correction. Usually all of us do serum calcium 48 hours later, unless the patient is symptomatic, has tetany, cramps, positive Schauf sticks, or carpopedal spasm. But those of y'all who practice daycare surgery, there are various tests described: serum calcium, immediate post-op, serum PTH gradient, slope of calcium, and literature is replete with these tests at various time points and at various cutoff values. And I'm not going to spend my time talking about them, but most of us don't do daycare surgery, so we do the calcium 48 hours later. And we'll only treat patients, and I've just put this up again for completion. There's certain criteria by which you divide your hypocalcemia. They're known as the Laurenti and Pusch's criteria. But basically, we will treat if the serum calcium is less than 8, 24 hours after surgery, and or the patient is symptomatic. There are 2 methods by which you would treat these patients post-operatively, 2 strategies. One is called the stimulating strategy, where you under-treat your patients. The aim of the stimulating strategy is to maintain mild but asymptomatic hypocalcemia. And this will stimulate your parathyroids to get back to normal. The other strategy is the splinting strategy, which is called rest and recover. And it refers to treating adequately with calcium and vitamin D to ensure that your calcium remains in the normal range. And observational studies suggest that this reduces metabolic stress on an already injured and ischemic gland, akin to putting plaster on a fractured limb. Literature again has proponents for and against. It's important to remember that if you do the stimulating strategy, your incidence of temporary hypocalcemia is lower and you can discharge your patient faster. And in the absence of literature supporting one over the other, my strategy is the stimulating strategy for my patients who have biochemical hypocalcemia. I'm ending with the last and a very exciting part of hypoparathyroidism. And there's a lot happening in literature because I told you if you have hypoparathyroidism, you can have an increased rate of death, you can have neuropsychiatric illnesses, and what not that you can have. So there are four areas by which there's a lot of research going on in today's world. One is allo transplants of the parathyroid, but generally rejection is high. Fibrosis occurs in the gland. You need immunosuppressive drugs, and it may not be the best approach. So people had looked at culturing parathyroid cell population, which is non-immunogenic. And if you Google or if you look into PubMed, you'll find some studies that show that this pathway has good promise. The third area that's being researched is stem cell research. And parathyroid like cells are cultivated, again with some initial good results. But I think what's more exciting, 2007 FDA approved it for non-thyroid reasons, but subsequently it got reinforced in 2015 and European approval in 2016 is recombinant PSH. And recombinant PTH is of two types, the 1 to 84. And if you remember your biochemistry, the PTH molecule has two terminals, N and C, and 84 amino acids. And the smaller, more active that has 30 odd amino acids, which is used for osteoporosis. But this is out there, has been used in more than 16,000 humans, not really advocated because it has been shown to have limb sarcoma, osteosarcoma in rats, plus high costs. But it is there, and probably as we refine and get more indications, we may have recombinant PTH to save our patients from distressing high doses of calcium and vitamin D and complications of that. I'm concluding by saying parathyroids, you must have a thorough knowledge of the anatomy, experience, do meticulous bloodless surgery to save the parathyroids. Remember, total thyroidectomy operating on both sides. More risk to your parathyroids and nerves. So if hemithyroidectomy is okay, please stay with that. Doesn't hurt your ego that you have to do the total and exactly same logic. There's no shame to leave behind a little nubbin of parathyroid to safeguard the nerve or the parathyroid. Always secure the superior parathyroid on the contralateral side. And I told you, Sons, that one parathyroid is okay. If inferior is not found, look in the specimen. You'll always get it there 9 times of the 10. And like I showed you, fancy gizmos, autofluorescence, loops, and various other harmonic devices at present don't have robust data to replace good, safe surgery. Dr. Shah always ends with one of his pearls of wisdom, and I'm going to give you all my pearl today. And this is something that I would want the youngsters and even seniors to know. The parathyroid is difficult to locate and recognize. Once you find them, you need to handle them with care. Sometimes you think you've been good, but they still don't function and you wonder why. And rough handling changes the color of the parathyroids, they blush, and they go into shutdown. Now, guys, remember that you have to do this with the parathyroid. Locate them, handle them with care. If you even think you're careful, sometimes they shut down and don't allow them to change color. And not only the parathyroids, this is how you would treat a beautiful lady as well. And lady surgeons, please remember, every time you handle the parathyroid, think how you want the guys to treat you, and just you will get no incidence or a low incidence of hypoparathyroidism. If you're not doing well and you're still changing color and shutting down, change tactics and auto transplant, and just extrapolate this into your daily life. Thanks once again for the opportunity. I hope I've not overspilt more, but I tried to make it as concise and as practical as possible. And after Claudio's talk, I'd be delighted to take any questions or on the panel. Thank you very much, Kaustubh, Rajendra, Aditya, and the entire team.
Thanks a lot. Thank you very much, Dr. Anil De Cruz. It was wonderful to listen to you. And no words. There are questions there is a flurry of questions coming in the chat box, but we'll be taking them, as you said, after the lecture of Dr. Sarnia is over as a together thing. So now, after that inspiring and in-depth talk by Dr. Anil De Cruz in his own inimitable style, we move on to a man who deserves an introduction but doesn't need one. Dr. Claudio Sarnia is a professor of head and neck surgery at the Sao Paulo Medical School, Brazil. He has served as the president of the Brazilian Society of Head and Neck Surgery. He has also been a member of Executive Council of AHNS and IFNOS. He has been involved in the publication of more than 150 peer-reviewed papers and multiple books. We famously know him from the Cernias classification, and that is exactly what we want him to be talking today: neural issues in parathyroid and neural issues in thyroid surgery. Without wasting any time, I welcome Dr. Claudio Cernia.
Thank you very much, Dr. Yoshipura. And I'm going to share my presentation now. Thank you very much for this kind introduction, and thank you for the invitation to belong in such a distinguished panel of discussion, and as well as after this marvelous conference that Professor De Cruz just gave, always learning from him. So we are going to speak about the neuro issues in thyroid surgery, and again, I'm going to try to share with you some of our experience with practical tips, as Anil just did. I have no conflicts of interest. And among the complications of thyroidectomy, I'm going to focus on nerve injuries. First, about the inferior laryngeal nerve, and after that, about the external branch of the superior laryngeal nerve. Again, for the youngsters, I think the best way to avoid the nerve injuries is to have a deep knowledge of the anatomy, gentle handling of the structures, meticulous hemostasis, and I'm going to focus a little bit about neurophysiological identification of the laryngeal nerves. We are going to start with the inferior laryngeal nerve for the youngsters. The left goes around the aortic arch, the right goes around the subclavian artery, and they go towards the larynx and have a very intimate contact with the thyroid gland. Obviously, there is a potential injury by dissection of all these structures, but mainly this area here, the Barry's ligament, right here. In addition, metastatic lymph nodes in level 6 may compromise also the inferior laryngeal nerve. I attract your attention. I'm going to focus to two potential variations, potentially dangerous anatomical variations: the extralaryngeal branching and the very, very dangerous non-recurrent inferior laryngeal nerve. When we are talking about extralaryngeal branching of the recurrent nerve, each branch must be carefully preserved, because usually there are no intralaryngeal anastomosis, and one branch goes towards one intrinsic internal laryngeal muscle. The branching frequency is very, very variable. We took a look at that in our own experience a while ago. This was published 11 years ago. And we had the records, photographic records of about 2,154 nerves, of which nearly two-thirds actually had branches, as you can see here. And obviously the vast majority of them had only 2 branches, but you can see here in this picture, single trunk recurrent nerve, bifurcated, 3 branches, and very rarely in our experience, 4 branches. But I advise you to be very, very careful with the non-recurrent inferior laryngeal nerve. The origin of this, on your left-hand side, you have the normal nerve, but on the right-hand side, you can see the recurrent inferior laryngeal nerve due to a vascular anomaly in the intrauterine life. You can clearly see here that on your right-hand side, the nerve goes directly from the vagus nerve behind the common carotid artery towards the larynx. So if you're not aware of that, you try to dissect in this area without being aware of this possible anomaly. This is a very dangerous situation, especially for non-experienced surgeons. The frequency of this nerve is very variable in the literature. I have a personal experience of 32 non-recurrent inferior laryngeal nerves. And these are only two cases that I had in my experience. You can clearly see here the nerve going directly from the vagus nerve towards the larynx. And this very curious case, I had to do a central compartment neck dissection. And it was very odd to do this dissection without having the nerve, which in this case goes directly towards the larynx, in order to have the nerve on the right side as a reference, an anatomical landmark to base upon your dissection. I remind you that this neuroanatomical abnormality occurs only on the right side, except if there is situs inversus totalis. From 15 to 16 years now, we've been doing monitoring of the inferior laryngeal nerve, as well as the superior laryngeal nerve. We're going to talk about that later. And in the initial experience, pay attention to this number. We had a very low frequency of injuries, but the negative predictive value, meaning negative predictive value of injury that you obtain at the end of the lobectomy, in our experience, and this is reproduced among the other publications, is around 100%. Meaning, if you have stimulate a nerve and you have function of this nerve at the end of the lobectomy, you may be almost absolutely sure that this nerve is functionally intact, not only anatomically intact. Keep this in mind because we are going to go back to this in a moment. There are some meta-analyses. I don't have time to elaborate too much on this, but there are some meta-analyses showing very clearly there is a significant reduction of the recurrent nerve transient paralysis with the use of nerve monitoring. And these are the three findings. You can clearly see here that there is a trend towards better results when you use nerve monitoring for transient paralysis of the vocal folds. And this is the largest meta-analysis, a recent one, 3 years ago, and shows very clearly that the odds ratio is very convincing. We gave a contribution on the recognition of the non-recurrent inferior laryngeal nerve with nerve monitoring. And we had 10 patients with non-recurrent inferior laryngeal nerve. And the tip here is when you are doing the vagal stimulation, the V1 we are going to see in a minute, what is that? If you get very different results on latency, stimulating here and here, you can be absolutely sure that you don't have a recurrent nerve like that. But if the latency is very, very low and you don't have any stimulus right here, you can be sure even before starting to dissect it that this nerve is a non-recurrent one. I suggest to the younger people in the audience to refer to this paper published by Greg Randolph and the International Group of Nerve Monitoring that we belong to. And this is an algorithm that should be adhered to very strictly if you are going to use nerve monitoring during thyroidectomy. L1 is the laryngoscopy before the surgery. V1 is the initial vagal stimulation with the probe. R1 is the initial inferior laryngeal nerve with the probe stimulation before starting the removal of the lobe. R2, V2 are all the results at the end of the lobectomy, and I call your attention to this V2, which is the most important one, and obviously L2 is the post-operative laryngoscopy. And this is V1. I hope you are hearing that. This is R1. And pay attention that only the anterior branch here is on the right side, is motorly active to the larynx. R2, a different case, after the removal of the thyroid lobe. And V2, which is the most important one, after the removal of the thyroid lobe. So which are the main advantages of the inferior laryngeal nerve monitoring? Well, we wrote an article on that, and the main advantage is actually to detect the loss of the electrophysiologic signal of the nerve after the lobectomy, of course. And if you are planning a total thyroidectomy, please consider to abort or to postpone the contralateral lobectomy, waiting for the complete recovery of the contralateral nerve, which is going to happen in the vast majority of the cases, especially if the nerve is anatomically intact. This is actually the only way to avoid bilateral vocal fold paralysis, which together with the hematomas are the only immediate life-threatening complications. And obviously you have to do a tracheostomy, even temporary, which is a catastrophe. In fact, we our group published these guidelines in the laryngoscope 2 years ago. And I am just going to share with you this algorithm, which when you detect a loss of signal at the end of a lobectomy, if you are considering total thyroidectomy at the beginning, please consider a staged contralateral surgery, waiting for the recovery of the nerve, and to completely avoid the possibility of a bilateral vocal fold paralysis, which is catastrophic, as I mentioned. In the same issue, in the same supplement of laryngoscope, this is for initial tumors, not very advanced cancer, so forth. There is another guideline for you to deal with aggressive tumors when you have loss of signal in the initial site. So I should strongly suggest you to consult this. The second part of this talk is how to avoid injury to the external branch of the superior laryngeal nerve, because there is always the possibility of injury of this nerve during the ligature and section of the superior thyroid vessels. What is the function of this nerve? It approximates the cricoid cartilage to the thyroid cartilage, stretching, increasing the length of the vocal fold, and it's essential for the production of high frequency sounds, especially among women, female patients, and voice professionals. The problem about the frequency of this nerve injury in thyroidectomy is that it's very hard to document, even with video laryngoscopy or video stroboscopy. The only way to absolutely be sure that this nerve is injured is with electromyography. Many years ago, we published in 1992 this classification of the nerve, and this is a small clip showing you the type 1, which is the most frequent one. The nerve is situated quite above the superior thyroid pole. Type 2A, the nerve is very close to the superior pole, but still above. And the type 2B, which is the most dangerous situation, the nerve is situated below the superior thyroid pole and goes towards the cricothyroid muscle after that. And this is a real case. This is an old picture. It's a picture from the original study. And you can clearly see here, this is the upper border of the superior thyroid pole, the nerve coming here and going back to the cricothyroid, towards the cricothyroid muscle. So if you just put your ligature, whatever you do, suture, clip, ultracision, whatever, here you are going to injure this nerve. So in that particular study that I mentioned to you, 1 out of 5 nerves had this kind of type 2B configuration. So if you are a busy thyroid surgeon and you operate, let's say, 100 thyroidectomies a year, there is the chance that you are going to see 20 cases with type 2B nerve. So in the second part of this study, we did a surgical randomized study. I don't have time to go to all of this, but just to attract your attention that the group 1 was operated. At that time, there wasn't nerve monitoring, just nerve stimulation. And the group 1 was operated by myself, actively searching for the nerve with a nerve stimulator. And this group 1 was the only group in which no injury whatsoever, only small thyroid glands was observed. The group 2, I was looking for the nerve without any particular search. What happens if the patient has a very, very large thyroid gland? In this clip, we can see that we had a hypothesis that actually the nerve gets closer because of the enlarging of the thyroid lobe. So would the type 2B could be more frequent, more prevalent in this particular instance? So we published a paper studying only very, very large goiters. The median weight was 431 grams. And at that time, we didn't have monitoring, but we used nerve stimulator like that. And in fact, on the left-hand side, you'll see the first study with normally sized thyroid glands. And here with very large thyroid glands, the frequency of the type 2B nerve, that nerve that comes down and has a very close contact to the superior thyroid pole, was much higher. Again, that group that I mentioned to you, the International Neuromonitoring Study Group, we published some guidelines for how to preserve with nerve monitoring the superior thyroid nerve. But here, it's suffice to say, this is the contraction that you want to see. So even if you do not have monitoring, just with a stimulator, very cheap, $10 stimulator, you can do a stimulation of the superior laryngeal nerve, and you have this kind of response. Very clearly seen at the end of the lobectomy. So the algorithm that the guidelines of that paper recommend is you should expose the superior thyroid pole, blunt and and delicately dissect the superior thyroid pole, and actively search for the external branch with nerve stimulation or monitoring if you do have, but check for this contraction of the CTM and orient this dissection until the external branch of the superior laryngeal nerve is identified and left, obviously, in the patient. And at the end of the lobectomy, check the functional integrity of the superior, the external branch of the superior laryngeal nerve, like so. So then you can be sure that this patient is not going to have an injury. So in order to stick to the time, I have some take-home messages. I didn't put my name here, I'm sorry, but the take-home messages, especially for the younger members of the audience, is concerning the recurrent nerve. Please be sure that there is always risk of injury of the inferior laryngeal nerve during thyroidectomy, especially near the Barry's ligament. All surgeons must be very aware of the anatomic variations. And as I showed you, the extralaryngeal branching is actually more common than the single trunk. And you have to very carefully identify and preserve every branch. I've been using forever, for more than 30 years, loops. Now I use a 4.0 wide-angled loops with a headlight. And I believe that this makes a major difference for dissecting the branches of the both nerves, the external and the inferior laryngeal nerves, as well as preserving parathyroid glands, as Dr. De Cruz very masterfully showed some minutes ago. Be aware that it's possible on the right side to find a non-recurrent inferior laryngeal nerve. And if you are not aware of this possibility, you are certainly going to cut the nerve thinking that, oh, an inferior laryngeal nerve never crosses perpendicularly this way. I am convinced that the neuromonitoring techniques actually are here to stay. They reduce the risk of transient injury, and you may say, well, transient injury is not a problem. If you are operating on a voice professional, and sometimes it takes 6 months for him or her to recover, I believe this is a major, major complication. The main advantage, and this is a very important message, the main advantage of the neuromonitoring is, in the case of loss of signal, please consider staging the contralateral lobectomy to avoid the risk of the catastrophic bilateral vocal fold paralysis. Talking about the external branch of the superior laryngeal nerve, the nerve is very important for the production of high frequency sounds. Therefore, for female patients, and especially for voice professionals, this may be a very, very complicated situation in the post-operative period, especially if it's bilateral. Keep in mind that 20% of the external branches of the superior laryngeal nerves may be type 2B, and you have to pay attention, and just putting our sutures close to the superior thyroid fold is not enough to keep the function of this nerve. As I mentioned, be extra careful when you are dealing with voice professionals, especially if they have large goiters. And finally, nerve monitoring helps to identify the external branch of the superior laryngeal nerve and to reduce the risk of injury. Again, I'd like to thank the organizers very much for the opportunity to be here with you. This is our medical school, the University of São Paulo Medical School. I am a professor of this institution, which is considered to be the very best medical school in South America. I graduated there. I did a general surgery residency there, head and neck surgery, PhD thesis, a full professorship thesis. So my history with this institution goes back 46 years already. So this is our professional home, and my home is our home. Thank you very much for the opportunity.
Thank you so much, Dr. Sarnia. It was a wonderful, eye-opening discussion, talk actually. So now there's a flurry of questions coming in on the Q&A session. I suggest we take 5 minutes to answer as many as we can, and then we move on to the panel, because the panel will have a lot of interesting cases, and we can sectionalize them as needed. So the first question for Dr. De Cruz has been asked by Dr. B.R. Patil. How would you identify an intrathyroidal parathyroid, sir?
Unlikely. It's a very theoretical question. It's very, very unlikely that you're going to identify an intrathyroidal parathyroid. If you've not imaged looking for a parathyroid, I mean, in cases where you have hyperparathyroidism, you're doing your system, maybe you're doing other scans, there also it's very difficult. But on surgery, in my experience, no.
Okay.
Maybe
can I make a comment on that?
Please, sir.
Maybe the others can chip in. Claudio, yeah, sure.
Neil, something that I've been doing for some years already is, if you have the fortune to have your pathologist with you in the OR, I like, when I take the lobe, obviously I try to identify the parathyroid gland. If I did not find one or two parathyroid in that particular site, I take the lobe still in sterile conditions. I carefully check with the loop. I do that, not my assistant, to see if there is some subcapsular, which is very common actually, in order to reimplant. And then with the pathologist, right at my shoulder here. I take still in sterile condition the scalpel and opens it. I open the thyroid lobe. Two advantages. One of them is that even if I'm not a pathologist, I get a macroscopic visual culture of the surface of cut of cancers, goiters, etc. But more importantly, if I see something that resembles a completely intrathyroid thyroidal parathyroid gland, this is the only way. Obviously, if I did not cut the cancer and went to the parathyroid gland, if I just cut the lobe and found an intrathyroid or parathyroid gland, and this happened already about 6 times in my experience, is the only way you can reimplant that intrathyroid or parathyroid gland. So if you have good interaction with your pathologist, this is something that you can consider.
Two quick points to respond to this. One, even if you've got one intrathyroidal parathyroid, the other three are good and safe, you should be okay. Second, if you go and dissect into a lobe which has a cancer, I'm not sure how you're going to dissect in the vicinity of a cancer, fishing out a parathyroid inside. That's very, very dangerous. Third, the incidence of finding an intrathyroidal parathyroid, it probably could also be in an ectopic location. I mean, you can read different literature. Some people will tell you that intrathyroidal is very high, but by and large, in our experience, the ectopic location is more than the intrathyroidal. I'm rarely going to recollect where they've said there's an intrathyroidal parathyroid. But the point I want to make it is usually subcapsular, particularly the inferior. So when I do a thyroidectomy, my first step after ligating the middle thyroid is to dissect, hugging the inferior pole of the thyroid. And if I see a parathyroid, I put the clip there right in the beginning so that I'm absolutely safe on that inferior parathyroid. And then I go to the superior, or then I do the Delbridge technique, whatever day of the week it is and how I want to do my thyroid.
Can I add a point, Dr. Cruz?
Rajendra is looking amused. Rajendra, you want to say something?
Murad here.
Yeah, Murad. Go ahead.
Yeah, again, very theoretical, but since the discussion is how to identify an intrathyroidal parathyroid, and intraop ultrasound may help for that. Especially as you said, it's never very deep within the gland. It's usually just subcapsular. So a good intraop ultrasound would be able to make you sort of pick this up, or at least make you suspicious that that is a parathyroid. And then that you could dissect out and send for frozen. But this is very theoretical. As you said, you have got 3 parathyroids, and if not seen the 4th one, you're not going to look for it intrathyroidal.
I think we are having a panel discussion, Deepak.
It's okay. We have one family, Kaustubh.
Yeah.
Let everybody chip in. Dr. Shah can make.
I understand. I think Dr. Shah can have some inputs, and then we may go to the next question. Otherwise, we will not be able to finish off all the questions.
Okay, go ahead.
Yeah.
Madan is there as well. I can see Madan itching to get off the crease.
Since Anil has asked me, I think I will respond. I completely agree with Anil. I think his comments are very appropriate for parathyroid. Now, when Murad said that we use intraoperative ultrasound, etc., those are the cases where you are operating for hyperparathyroidism. And you can't find the enlarged parathyroid gland. And you think, that used to be the board question for the American Board of Surgery. When you don't find the last parathyroid, what do you do? Take out the lobe of the thyroid. That was a classical answer, because there may be an intrathyroid parathyroid. For a classical total thyroidectomy for cancer, I think the points that Anil raised are very important. You rarely have to, I agree about transecting the specimen with the pathologist, but I'm unlikely to take the parathyroid out and implant it. You do have 3 other parathyroids. And again, you have to realize that injury to one parathyroid or 2 parathyroids is a commonality. Our own experience of finding a single parathyroid in the total thyroidectomy specimen in the past was 13%. Now it is 20%, because the pathologists are now dissecting the thyroid specimen millimeter by millimeter and finding more subcapsular parathyroids or intrathyroidal parathyroid. The true intrathyroidal parathyroid is very rare. It does occur, but it is very rare. Majority of them are in the subcapsule. And don't forget that sometimes you may have a fifth parathyroid inside the thyroid, and you may be trying to spend a lot of time on that. Again, I don't want to take much time, but this is very important. I just want to add one more point because we are in northeast of United States. Vitamin D levels preoperative are very important. I never gave much importance to that till I started doing it for last 3 years. And I realized that when I did my own vitamin D level, it was miserably low. And then I realized why I'm losing my hair like Claudio. Claudio, check your vitamin D level. I realized soon that a large number of patients come with very low vitamin D levels. And if you have time, try to correct it as best as you can. Or if you don't have time, at least know post-operatively that this patient's calcium is not going to go up till we give them a load of vitamin D. Just keep that in mind.
So the panel has almost started informally, so I won't waste too much time of anyone. And I would like Dr. Deepak Abraham to take the center stage for this. We welcome Dr. Deepak Abraham, who is the moderator for the panel discussion on the complications in thyroid surgery, real life situations. Dr. Abraham is the head of endocrine surgery department at CMC Vellore with multiple national and international award-winning publications and a documented experience of many thousand surgeries. Hence, I assume a fair few complications too. Now, every panel discussion is enriched by a to and fro between an expert moderator and the razor-sharp, crisp answers given by the dignitaries as panelists. To that end, we are fortunate to have as panelists Dr. Ashok Shah, a world-renowned thyroid surgeon and the holder of the Jatin Shah Chair in Head and Neck Surgery and Oncology at Memorial Sloan Kettering Cancer Center, New York City. Dr. Madan Kapre, founding national president of Indian Society of Thyroid Surgeons with multiple authored books on thyroid cancer from Niti Hospital, Nagpur. Dr. Arvind Krishnamurthy, associate professor in the Department of Surgical Oncology at Adyar Cancer Center, Chennai. Dr. Sajid Babu, senior head and neck oncologist and associate professor, Malabar Cancer Center, Kerala. Dr. Kaustubh Patel, senior head and neck and robotic surgical oncologist at HCG Ahmedabad and the brain and the vision behind OM6. Dr. Murad Lala, senior surgical oncologist with special interest in head and neck and thyroid associated with Hinduja Hospital, Mumbai. Dr. Rajiv Sharan, senior head and neck surgical oncologist, Tata Memorial Hospital, Kolkata. And our two other lecturers from the previous sessions, Dr. Anil De Cruz and Dr. Claudio Cernia. We have a full house. I won't take too much of the time. I'd just like to lay down the rules for the panel, which I'm probably not in a position to do, but I discussed with Dr. Abraham regarding the cases. So after the case on calcium metabolism, we'll be taking the audience questions regarding PTH and other related issues. And after the cases on the nerve injury, we would like to take audience questions related to the nerve injury. And there are a few miscellaneous questions that we might take along the course or at the end of the session. Over to you, Dr. Deepak Abraham.
Okay. Thank you, Aditya. Can you see my screen?
Yes, absolutely, sir.
Okay. Thank you, Dr. Costa, Dr. Toprani, friends in Ahmedabad who I have joined from OM5. And so to me, I'm a new kid on the block. But I know that I do have some contribution to make in terms of thyroid surgery. And thank you for choosing a topic called complications. Now, to me, complications is a bad word in a surgeon's vocabulary. You would not like to be talking about complications. You would like to sweep them under the carpet and keep them, out of purview, out of vision from your patients, definitely, and from your colleagues. But, I would start with how do I get to my slide? Yeah. Complications in thyroid surgery is something which I really like to speak about simply because I'm a big fan of audits. Now, but before I start on complications of thyroid surgery, I'd like to bring you to the attention of this book by Atul Gawande, who is actually, I'm a big fan of him. I don't know if one of you are, but Atul Gawande writes about complications. And I'd like to start with a quote he makes by saying, no matter what measures are taken, doctors will sometimes falter. And it isn't reasonable to ask that we achieve perfection. What is reasonable to ask is that we never cease to aim for it. And I think ceasing to aim for it will always make you a person who will do audits. Now, I'll bat for audit, and that's because we are from a country which believes in cricket and we worship cricket. Surgery without audit is like playing cricket without keeping the score. Now, you can keep batting and batting and batting, but if you don't keep your score, you don't know how good you are. And there's a quote, there's a phrase which says, practice makes you perfect. I must tell you, practice will not make you perfect. Audited practice will make you perfect or get you better. Practice will only make you permanent. Otherwise, unaudited practice will only make you permanent. And you will do it the wrong way all the time. So with that in mind, how do we do it here in Vellore? And Vellore is down south of India. We are a tertiary care institution with about, my experience in thyroid surgery is about 600 operations in our department. When I say mine, it is my department. And this is what we do on a weekly basis. We write it's on a whiteboard out there in our conference room. It's written in hand, then entered into a register, then goes into a soft copy. So, we've got multiple entry points, but that is the cumbersome way of doing it. But I still believe that it's important to do it. You don't lose out on data. And we maintain our calcium levels on day 1, day 2, PTH, and I'll come back to that later. And we roughly do about 12 to 13 or 15 thyroidectomies a week. So that brings to about 600. So this is our data from our data sheet. And this gets translated on a yearly basis into an annual audit, which then is presented to the division of surgery, which is our larger parent body, who then criticizes us or critiques us and says, well done or no. So that's basically, I'd like to lay down the rules to say for young surgeons, maintain your audit, maintain your practice in terms of see how well you do in terms of surgery. And that, I think, is the bottom line of getting to be a better surgeon. And I'm sure that my esteemed panelists, my senior surgeons on the panel, Dr. Shaha, Dr. De Cruz, Dr. Madan Kapre, will agree that it's in audit that you will make a difference. And I firmly believe it because I'm a great fan of audits. And this is my thyroid audit for 2019. So we do it every year. And in CMC, in Christmas time, we don't have operating time. So we usually have a week of holiday. Every resident is being given a month from December to say, this is your audit, and you will present it by the last week of December or first week of Jan. And this is what we do, about 646 thyroidectomies last year. And we're roughly in that range, about 600 plus. And we have a mix of malignant and benign, malignant being more common than benign. But I want to show you this slide, which is actually something which is one, this is my nerve injury rate. And this is from across all, registrar, consultant. So it's about 2.3% of recurrent laryngeal nerve temporary palsy. And hypocalcemia of about 17%, which is transient post-operatively biochemical. And our permanent hypocalcemia is 2.8%. And this is data from 2018 when we do 2019 audit. And this is complications which are hemorrhage, which we would like to see. If you have time, we'll touch about it. It's about 1% of our patients have a hemorrhage, and only a few of them actually need to go back to an operating room. And chyle leak is another thing which we are looking at and saying, listen, man, why are we having rates like this? And I want to, this is what, if there's an area I'd like to improve, it's in this and in hypocalcemia. Coming to that, so I'll bring my first patient in, and all these patients are complications which we have experienced, most of them in the last year, some of them may be representative from the year before. So I had a 36-year-old gentleman who had a thyroidectomy in May of 2019. It was papillary thyroid cancer. Bilateral recurrent laryngeal nerves were preserved, and post-op voice change was there, and there's a right vocal cord palsy. I'd like to come to Dr. Ashok Saha and ask, how would you manage this patient when you have a hoarse voice next morning when you go for rounds?
If you have hoarse voice next day and you know that your nerves are preserved either by observation or by nerve stimulus, and the patient's airway is okay, he's walking around, I wouldn't do anything.
Yeah.
The question comes, would you like to do the fiber optic? I don't think the fiber optic is going to change, but you already done it. You know the vocal cord is paralyzed. The location of the vocal cord will help you to ascertain what kind of injury it is. But I don't think it is going to change anything. I would wait for 3 months and then start doing some laryngological workup. At this time, leave him alone. He will come back to normal.
I think
This is just a technical, you might have dissected more on the nerve, or there is you do have electrical stimulus, but functionally it is not working.
Yeah, perfect. So what we would do is are there any other panelists who would like to make a comment at this point of time? Murad or Sajid or Dr. D'Cruz? Yeah, I would like to say something. I'll just get Dr. D'Cruz, yeah.
I again totally agree with Dr. Shah, but I also keep in mind how rough my anesthetist was at intubating. There is a theoretical, and Murad said we are all being theoretical, so I also want to be theoretical. If you have an arytenoid dislocation, and I've really got my nerves beautifully, I've seen the branching, everything, and my anesthetist has been rough, I may in that case just put the scope in and have a look at the dislocation. Theoretical.
Sure, okay. Dr. Costa, would you like to say, what is the most common cause for this patient to have the palsy? You've seen a structurally intact nerve, and you possibly used nerve monitoring or no, but the patient's got a voice change post-op.
So most probably this is because of the neuropraxia.
Yes.
And that might be because of the dissection around the nerve segment where it might have been devascularized, or we might have to move the nerve sometimes in the process of dissection. So that might be the reason.
Sure. Okay. So it's most probably a traction.
But Deepak, answering the previous issue, I would definitely, this is a case of total thyroidectomy only. But if this would have been a case where the neck dissection has been done, I would definitely like to see if the patient is aspirating or not. Because high vagal injuries due to neck dissection can also produce vocal cord paralysis. But in that case, most of the patient might have aspiration, and there I might have to do something.
So you're saying that is more like a location can be put to play by saying, okay, if there's aspiration, it's possibly more distal and esophageal branches are being affected, and that's why they're aspirating. So, but still, would you intervene, Dr. Costa?
No, but I would definitely be careful whether he's not aspirating, or if he's aspirating mildly, I might have to put a Ryle's tube. I might have to treat him conservatively, see that he doesn't produce lung complications.
Any other suggestions from the other panelists who haven't spoken yet? Dr. Capre?
Yes, I would like to come in on this change in voice and vocal cord palsy, two different things. If the next day morning your patient has a change in voice, maybe a husky voice, it doesn't necessarily mean that he has a paralyzed vocal cord. There could be some other causes of a change in voice, like what Anil said, the arytenoid dislocation, there could be hematoma on the vocal cord, so many things. So I would insist on doing a laryngoscopy and confirm that it is a cord palsy, number one. Number two suggestion is that I always like to believe that we all do parotid surgery and all the parotid nerves are working fantastically on the table. Next day morning, one of the nerves start behaving little less, and that is the neuropraxia. So I always tell my patient beforehand that maybe even if I saved your nerve, and that's the importance of talking to the patient soon after surgery. And you see that the voice was good immediately afterwards, so it's going to be good. So that's just a little contribution from my side.
Sure. Okay. So the point was, confirming whether it's a nerve palsy or whether it is actually a voice change due to some other cause is what we are trying to say. Okay. But it's important to understand that we are not going to actively intervene in this patient. Wait for time. You'll see over 3 months, most likely they will recover. Their voice will be back to normal, and you may have a vocal cord check and an NPL scopy, and most probably recovered. And that's because of a transient traction injury from most often your assistant rotating your gland. Would that be okay in summarizing here? Would that be okay to the panelists? Dr. Sonia, any comments?
Dr. Abraham, may I just come?
Yeah.
Oh, I'm sorry. Should I speak, or Dr.
Yes,
Lala,
actually, I'll go to Dr. Sonia and then come to you, Murad. Is that okay?
Absolutely.
Sure.
Okay. So I think this is common situation, and I agree with Ashok. My only addition to that would be, I mentioned about the Barry's ligament, which is by far the most frequent point for breaks of the nerve. But also the dissection of the Zucker-Candle's tubercle. Sometimes the inferior laryngeal nerve, before going to the Barry's ligament, if the Zucker-Candle tubercle is very large or is enlarged, at that particular point, it's very possible to cause apraxia. And if the patient has an intact nerve, it was identified, an intact, anatomical intact nerve, it will come back the function quite soon.
Very important point. So I'd like, it sort of takes me to my next issue. So when I deal with a complication, the way I thought I would describe the complication, handle the complication, and then I'd come back to the panelists to ask, how would you prevent this complication on table, right? So, so would you like to come in, Murad?
Yeah, just a point about your previous discussion that we had. We don't always have to rush in to do a fiber optic scopy or a laryngoscopy for these patients, because as has been mentioned by Dr. Kapre, there are many other causes apart from just nerve injury that causes the hoarseness of voice.
Sure.
So as long as this patient is just asymptomatic apart from hoarseness of voice, there's no aspiration, I'm not going to, immediately do a laryngoscopy for this patient. The ideal time is when he gets discharged, when he comes back for a follow-up with his final pathology report. That time his pain is less, he's more comfortable. That's the time to do a detailed laryngoscopic examination and assess the cord motion.
Okay, so I'll come back to your point. I'll just sum up that. Any comments from Arvind and Sajid? I'll go with Sajid first and then come to Arvind. Yeah.
Dr. Anil De Cruz sir and Madan Kapre sir had already told what I wanted to say.
Sure. Okay.
So
that's fine.
That's the commonest finding that we see. Post-operative voice change is not always palsy. Second point is, most of the time, if we had a difficulty during surgery, especially we try to do a mini incision thyroidectomy, and there is lots of traction, we kind of urge towards having a palsy rather than and we had to bipolarize near to the nerve. We may have a suspicion in prior to.
Okay, Arvind?
I agree with all the points. In fact, up to 40% of the patients may have some degree of hoarseness, with both the vocal cords being normal. So again, it could be various issues. Some patients could have some minor complications, even sometimes superior laryngeal also. And coming to the aspect, another point is, I think it is very important for us to document the cord status post-operatively also. I may not want to rush in on day one, as you rightly said. We'll follow the conservative maneuver, but at some point of time prior to discharge, I would want to document whether there is a cord palsy there or not. And the other thing is about prevention. Of course, if you want me to take it, I will, or otherwise.
Okay. No, I think that's fine. So I'll sum up to say that your timing of or an NPL scopy could differ, could be a little later. All voice change is not palsy, right? And all palsy need not be chased in terms of having a scopy immediately. But I'd like to come to a more practical for participants is that I'll come back to the master, and from, as Aditya introduced Dr. Anil, what steps would you say or take as you go for the as you go to look for the recurrent laryngeal nerve?
What steps means surgical steps. So let me
intraop preventive measures to.
So let me make some very So let me make some very broad and simple comments. I'm not going to get into specifics of the surgery, but I'll make some comments. The first thing is, variability rather than vulnerability places the recurrent laryngeal nerve at risk. And I think Claudio brought that out beautifully in his talk. Whether it's a non-recurrent, whether it's a branching, whether it's the external laryngeal. So I want to give people the first message Don't get scared of the nerve. As I tell, unless you go and clamp it or you divide one of the branches or you swing on the recurrent laryngeal nerve, it's rarely unlikely to get damaged. And let's all look, forget all this rich literature with intraoperative monitoring and other thing. How often in your career have you had a bilateral cord palsy? Let's be honest. Suddenly we're getting scared. We won't do the other side. We won't do this. People will take us to court. It's rare. So the first thing that I would tell the youngsters is know the anatomy and the variations very correctly. The second, the recurrent laryngeal nerve has three parts. It has an infrathyroidal part, it has a thyroidal part, and it has a ligament of Berry part. Most surgeons who are above average, if you're a rookie, I don't know, if they have damage to the recurrent laryngeal nerve, it will be at the ligament of Berry part. You have no business doing thyroid if you are going to damage it infrathyroidal or relating to the thyroid, unless there's extra thyroidal spread or nerves. So that is the point number 2. There are 3 methods by which you approach the recurrent laryngeal nerve. You can either do a superior approach, you can do a lateral approach, or you can do an inferior approach. Inferior approach, you're coming from virgin area, you get the nerve, but the problem is the blood supply to the parathyroids. So usually I don't bear the nerve bare. I will hug the capsule exactly as Delbridge has described and take vessel by vessel, and then I'll see the nerve in the somewhere just before the ligament of Berry and follow the dissection accordingly. If it's benign, I'm not going to strip the cover over the nerve at all. I may not bear it nude, if I can use that word. I will only bear it at places where I need to see it and take out the lobe of the thyroid. And lastly, I'll be meticulous in my dissection, no blood loss and that kind of thing. And one last point I will make, the recurrent laryngeal nerve can branch. Branches that come above the inferior thyroid artery, between the inferior thyroid artery and point of entry, are motor branches. Branches that you see distal, that means downwards towards from the inferior thyroid artery, are usually sensory to esophagus and trachea. So please be careful of all branches after the recurrent crosses the inferior thyroid artery. So these are my few general comments, and maybe others can elaborate and add. Or yeah.
Thank you. Dr. Sonia, I'll come to you with what would be your tips and tricks of preventing an injury intraop?
Well, I already mentioned that in my talk. You have to be absolutely aware of the variations, anatomical variations there, as you mentioned already. You have, and I agree with him also, that varies very much according to what are you operating. If you are operating a substernal goiter, for instance, you have to try to dissect the nerve in the upper situation, especially on the right side. Because remember, the path of the nerve on the right side is more oblique compared to the left side, where it's more vertical. So especially nodules posterior to the nerve can actually bring the nerve superficially, and someone who is not very accustomed to that may injure the nerve exactly at that point. So the 3 approaches are depends on the case. And as Dr. De Cruz mentioned, I try to find where the nerve is, but the dissection has to be very subcapsular and close to the thyroid gland in order to avoid devascularization of the parathyroid gland. Because if you do skeletonize the nerve all the way up, you may devascularize the parathyroid gland.
Sure.
So
perfect. Thank you.
These are.
Yeah, that's great. So just to sum up there, just to say that we.
Can I add one point?
Yes, please.
Yeah, this is Ashok. I just want to add 2 points. I think there are 2 important issues. It is extremely rare in a seasoned or practicing thyroid surgeon to injure the nerve directly by transecting or crushing. It is most of the time traction injury or thermal injury. The nerve goes near the ligament of Berry and then it goes posteriorly. That angle, you may be putting a traction on it. And as we are cutting the ligament of Berry, remember, there is always a stupid artery of Shaha there. And that artery starts bleeding. Once it starts bleeding, your direction, your whole mentality changes. Now you start controlling the bleeding. And in an effort to do that, either you put a clamp or you use a bipolar or electrocautery, and there is a thermal injury. It is extremely rare one would cut the nerve, but it is the most common cause is thermal injury or traction. We call it stupid artery of Shaha, or as Claudio Cernea would call it, artery of stupid Shaha, but it doesn't matter. It is a simple, small artery. And one other point I just want to bring up about the non-recurrent nerve. I think the presentation by Claudio was excellent, but very important. If you have done a CAT scan, which we do quite often for large thyroid tumors or even benign goiters with contrast, look at the CAT scan yourselves to see if the innominate artery is retroesophageal, what we call as arteria lusoria. And keep in mind, many radiologists won't report it because they're not familiar with that anomaly. We know that as a thyroid surgeon. And the patients where you find the retroesophageal innominate, that's the patient who has a non-recurrent nerve. Just keep that in mind.
Yeah. Thank you. Thank you. That is very valuable. So just to say, I'd like to add on some comments which Dr. Lee Delbridge, who I trained with, says, you don't go looking for the nerve comes looking for you. You stick to the capsule of the gland, you rotate the gland, you encounter the nerve. The recurrent is a very robust nerve. It's you've got to be pretty unskilled to damage the nerve by, as Dr. Shah has said, cut the nerve, or you wouldn't have a transection. And especially when in the segment which is closest, which is at the Berry's ligament, is actually protected by the tubercle. The tubercle of zugocandle, 90% of the time is over the closest point. So look for the nerve only at the point where it's closest, and that is at the point of entry. And the tubercle is sitting like a nice hub or a kind of a cap there to protect you. And then you make your dissection clear, and you can rotate your gland away and do a complete thyroidectomy without leaving back or leaving behind thyroid tissue at the Berry's ligament. I think that those were points which, so he used to keep telling me, you encounter the nerve, you don't go looking for the nerve. The nerve will come looking for you, because when you do it in the right planes, as everybody mentioned, you hug the gland and stick to the capsule. As you rotate, you will see the nerve. And I think the important thing is, don't become nervous about the nerve. And I think junior surgeons should know that. The problem is people become, where's the nerve? Where's the nerve? I had an assistant with me when I was operating in an outside institution. Every single structure for him was a nerve. I said, no, that's not the nerve. Don't worry. The nerve will come at its time. So look for it at the right time. It will be there. And so rotating the gland, looking at the point of entry, keeping the tubercle as your landmark, looking for the nerve underneath will help you pick up or find out these nuances about the nerve. Okay, so for want of time, I'll move on to the next aspect of the next patient. Oh, okay, yeah, this is actually a picture. This is the tubercle. That's the nerve. And this is the fascia which you need to, as you rotate the gland, you will find that the nerve is nicely hugging, sort of snugging underneath there. And you just rotate the gland and you've excised the whole gland without actually having to leave behind thyroid tissue. There are situations where 10% of the time you can have this nerve on top of your tubercle, as was mentioned. In terms of variation is a problem, vulnerability is not the problem. And it's the variations you as a surgeon, as you master the art, you will get better and better at identifying those non-recurrent nerve and the variations and the branching. And I think you keep doing more and more and audit yourself. You'll say, okay, I did something wrong last time. Let me see, I don't do it again this time. Is that okay? Can I move on to the next? Okay, this is just to show I think was mentioned, see the difference in the tubercles on either side of the specimen. You'll see a one small tubercle on the right side of the slide and the large tubercle on the left side, which is the right lobe basically. And you see that is what I would like to say is crucial in sort of identifying that the nerve is sort of snugged underneath this point. Okay, I'll come to Dr. Cernia because we've got the gentleman in place. This is a picture I captured about him when he had a little more hair, I think, Dr. Shah. This was when he was in Delhi. This was in Delhi a couple of years ago when he came. And I cropped myself out of the picture to keep the thunder on him, right? So, and I'll just tell you his classification, which he mentioned. But I'd like to say, you know, can you share the tips and tricks which you mentioned in your talk, and how would, just to reiterate, how would you preserve the EBSLN?
I like that picture. I don't know if you sent me, but I look very handsome in that picture. Ashok, don't say anything.
Not as handsome as me.
Ashok, mute your microphone, please. Well, the main thing is that, as I think I mentioned in my talk this time, I think that magnification, especially for the external branch, is very important, because this is a tiny nerve, is not as robust, as I said, as the recurrent laryngeal nerve. And in fact, again, out of every 5 superior thyroid poles that you see, you have the chance to find a nerve crossing the vessels below the upper thyroid pole. So I try, before I cut everything, I usually use ultracision, but whatever you do, you put a stitch, you put a clip, try to identify the nerve. I am fortunate enough to have in my private practice nerve stimulation, nerve monitoring, but you actually do not need monitoring. You just stimulate with 1 milliamp, and you can clearly see right in your picture there at the on the cricothyroid muscle, the contraction. And then you can sort of map the nerve if you have nerve stimulator. But anyway, even if you don't have, which is in the public health system in Brazil, we do not have, don't worry. Use your magnification, your eyes, dissect very carefully, bluntly, and try to, to cut the branches of the superior thyroid artery. Usually there are 3 branches, 2 anterior and 1 posterior around the superior thyroid pole. So try to cut them as caudal, as inferiorly as you can. And that's how I suggest you to try to preserve the nerve. If you are dealing with a very large thyroid lobe, keep in mind that that particular situation is very dangerous to injure the nerve.
Sure.
I think these are the practical tips I can give.
I just bring in Dr. Capre because he's been silent. What would you add on? Would you just say that, how would you practice? I mean, I think that would be a good way to go. How would you practice to save the superior laryngeal nerve?
Yeah, my take on saving the EBSNL is really skeletonize the vessels at the upper pole. Each, as he said, there are 2 anterior, 1 posterior, and they are accompanying veins. So get each vein and each artery separately, and then that is your way to save the type 2B. Because type 1A, type 1 is usually saved and not much skill is required, but the skill is required for the 2B. And this is my advice, that you skeletonize each single vessel and ligate them singly and just count them. I need to count them 1, 2, 3, 4, and then I say, oh, that's the 5th one coming at the posterior half of the upper pole, which is the artery. My observation, and I would like Ashok and Anil and Cernia and everybody to chip in here, is likewise the recurrent nerve. I have observed that the external branch of the superior laryngeal nerve also at times divides before it enters the muscle. And I have got pictures demonstrating sometimes even 2 or 3 branches, because I took that lesson off while doing a laryngectomy, that the nerve is very robust. But sometimes when I saw people demonstrating in session, that nerve wasn't so robust. It was little thin. And I said, maybe they're showing a branch and not the real EBSNL. So if you want to, in brief, my suggestion is skeletonize, skeletonize, and skeletonize. And that's the way you save the EVA cell. Skeletonize the vessels.
Any other points, Dr. Kaustubh and Murad after that?
I agree to what Dr. Madan and Dr. Sarnia says. There is one variation which I do. I start following the anterior border of the superior upper lobe of the thyroid. So anything which is going from thyroid towards the muscle or larynx, you must be very careful. That is the time where you must have in your mind type 2B, because if the nerve is crossing the thyroid, it has to go out of that thyroid anterior border to enter the muscles and larynx. So by seeing those areas going upwards towards the upper pole, you will definitely be able to see the nerve first, and you'll be able to know and you can preserve that nerve.
Sure. Okay, Murad?
Yeah, exactly what Dr. Kaustubh said, but in a different way. What I do is I create the reeve space, the potential space that's there. I get the upper lobe away from the cricothyroid. I sort of put a little downward and outward traction on it. That creates the reeve space, and then follow exactly what Dr. Kaustubh said. Make sure none of the small branches that I am going to ligate, make sure it's going into the superior pole and not then crossing and the reeve space and getting into the cricothyroid. So that's what I do for the superior pole.
So I think I'll wrap up here to say that, yes, I like Dr. Sarnia's thing. You look for this nerve. The recurrent laryngeal nerve will come looking for you. The external branch, you better go looking for, right? And the way to do that is actually what Murad was saying, is capitalize on this space of Reeve. Reeve is Tom Reeve. Tom Reeve was Lee Delbridge's boss. And Tom Reeve said that dissection into this space will help you find out the external branch of superior laryngeal nerve and the classification as described by Dr. Sarnia. So I think the point is, look for the nerve, look for the external branch, stick very close to the capsule, identify, ligate the branches of the superior thyroid artery, the two anterior, the two posterior, whatever, but stay close. In fact, you can actually ligate the vessel even below the apex of the superior pole, because you will see that the vessel courses over the superior pole, sitting like that, and you can actually ligate it off lower down. Either you seal it with an ultrasonic or ligature or whatever, or you could even just use a tie. So I think
Deepak, can I make a point?
Yes.
While I agree with, again, everything Madan, Kaustubh, you, Claudio have said, but I'm not going to be sacrosanct about searching for the external branch of the superior laryngeal.
Yeah.
Claudio's classification, or my simple classification, in 1/5, it's very high up. In your enthusiasm to poke into reeves, it's not really avascular on top. You get a little bit of bleeding, you go put your bipolar in there to try to get hemostasis, and you're going to screw up the nerve. Sure. Be careful of the 2B. If you don't see it totally and you've done your 2B precaution, go home.
That's
don't
right.
say Deepak said keep searching, you'll end up with a hematoma. You'll get cricothyroid muscle myositis when you buzz that
so
muscle, it fibrosis, subtle voice changes will occur.
Point taken to say that, as Dr. Sarnia showed, 64% of the time only you will see the nerve. But when you look for it at the point of the upper pole. Stay close to the superior pole, ligate the vessels. If you don't see it, fine, leave it alone. Don't go looking for it. Further than what was looked for in the space of reeve, close to the upper pole vessels entering into the superior gland or superior lobe pole. Is that okay? So we don't go looking high up, especially trying to see the one. You will not see one. It's best not to see one. It's 2B you're looking for, and 2A to a certain extent. Stick close to the upper pole, ligate your vessels, exploit the space of reeve so that you'll see it coursing, and then leave the, if you don't see it, don't go further up. So with
Dr.
that,
Abraham, can I make just a small comment on that?
Sure.
I think it's very important to, in these times where robotic thyroidectomy, especially the TOETVA, is becoming very, very popular. I like to raise a word of caution against mass ligatures of the superior thyroid pole. I think all the other panelists mentioned that individualizing the ligation of the superior thyroid pole is very important. In this kind of robotic surgery, and again, I do robotic surgery for oropharynx cancer, but I do not like to do, at this moment, robotic surgery for thyroid, exactly because I am very, very concerned about mass ligature with sealing devices or clips, whatever, that you must perform when you are doing robotic transoral thyroidectomy.
Sure.
Thank
Okay.
you.
Thank you. We'll move on to the next issue, which is about another aspect of the nerve injury, and that is, what would you do when you have inadvertent transection of the recurrent laryngeal nerve? This was a patient who was operated in one of our peripheral satellite hospitals when our team went there to operate. And my surgeon, the team who went there, had an inadvertent transection of the recurrent laryngeal nerve. How do I proceed now, Dr. Shaha? You've been very quiet. Yeah.
That's an interesting subject. Number one, I must say, the true transection of the nerve that the surgeon has identified in the operating room probably will happen once in your lifetime. But that you will remember for the rest of your life.
Absolutely.
You know, Barry Inabnet used to run a master's course when he was in Mount Sinai. And the first year he organized the course, he gave me a subject, didn't ask my okay or not. And the title of this presentation was, I have transected recurrent laryngeal nerve. What do I do now? And I made a slide. I said, fly Air India, New York to Bombay, one way. Don't come back. It's something that you will hurt your feelings all the time. The first thing is most important, blame somebody else. Blame your resident, so that as attending, you're always still sterile. No, the point is, if you are transected the nerve, number one, can you see two ends? If you see two ends and they are anatomically very close to each other, get some loops and put 9/0 nylon on them. 2 or 3 stitches is enough. Make every effort to reanastomose that nerve if you can see the two ends. If you don't see the upper end or the lower end, then you need to take the ANSA. The ANSA is readily available on that side. Again, bring the ANSA and put 2 9/0 nylon stitches. If you don't find the proximal end, which is fairly common, or whatever you want to call the end near the larynx or cricopharyngeal muscle, then you can dissect into the muscle to look for the branches and take one of the branch and anastomose that with the ANSA. If you have done a neck dissection and ANSA is sacrificed completely, or it is a reoperative surgery, you can go to the other side, pick up the ANSA and bring it behind the esophagus. But that's quite an enormous work. If you have the two ends, which is not uncommon, that you have not transected the nerve, but you have transected the nerve intentionally because there was cancer invading the nerve. If that has happened and there is a gap of 1 centimeter or 1 inch, then take one of the branches of the ANSA or greater auricular nerve, which is also readily available, and do interposition grafting. But if you have intentionally or unintentionally injured the nerve, reanastomose it as best as you can. It won't bring the vocal cord function normally. The vocal cord won't move, but it will do the internal tightening of that vocal cord. What I call is internal laryngoplasty, and the voice will become normal. We have one patient who was a singer. We sacrificed the nerve purposely because of the cancer and reanastomosed with the ANSA. And 3 weeks later, she sang the same voice as she had before. Amazing.
So I think that Dr. Shaha, you did me a great favor. You've answered every aspect of it. And I really don't need to spend too much more time on this. I think if you have, the bottom line is, If it was inadvertent, there's no gap, you would do primary anastomosis. If there's a loss of a segment from a willful sacrifice from cancer, you would bring in the answer. You would do something to interpose, and so that it is not that the vocal cord is going to function, it's not going to become mobile, but the voice will definitely be better. And as you said, that internal laryngoplasty. And I think it's important. In my patient, we use 6O because simply in that peripheral hospital, we only had 6O and we didn't have an operating microscope. So in our main hospital, if we've had a problem like this, we would actually get, we have the luxury of calling the hand surgeon or the plastic surgeon to actually do and use the operating microscope and do that suturing with a 9O. So, but you know, the point was the vocal cord palsy did not recover, but the voice recovered. How good it was, maybe a fine professional voice user would have seen the difference. But as Dr. Shah just mentioned, they could sing the same thing even when the transaction due to cancer was done. Any other comments which are outside of this? Dr. Kostav, you'd like to say?
Yeah, actually, I understand, agree all these things. One question which always comes to my mind is that why we can't anastomose the vagus nerve to this nerve? Why? Why literature is not saying anything about it?
It has been described anecdotally. The problem with the vagus nerve is if you have to cut the portion of the vagus nerve like we used to do for the facial nerve, you know, the hypoglossal transfer. The problem is you don't know which portion of the vagus in the 360 degree is motor to the larynx, and you may injure the vagus and injure the recurrent right there. So you have damaged the mother nerve in an effort to preserve the child. And you probably heard, but there are some descriptions in the literature. They're anecdotal. They have not been followed critically with the nerve, with the laryngoscopy, fiber optic, or with the EMGs. So I would caution using the vagus at this time.
Yeah.
May I make a comment on that?
Yes,
there is a French surgeon, very respected, and he has a huge experience in bilateral, not his cases necessarily, but he takes care of patients with bilateral vocal cord paralysis after thyroidectomies, and all the patients had tracheostomy. He published that a while ago. And the best results he had with re-innervation with a partial dissection of the phrenic nerve, the ipsilateral nerve, and anastomosing it to the distal stump of the recurrent nerve. It's amazing. He could actually decannulate a good amount of patients doing that.
Well, that's very interesting. Is that Dr. Charles Proy? Is that Dr. Charles Proy? Dr. Sonia, was it Dr. Charles Proy?
No, his name is Jean-Marie.
Okay.
Jean-Marie. He's not proboscis, not Proy. Yes.
Deepak, can I come in here for a while?
Sure.
On the cord palsy?
Yes, please. Go ahead.
Yeah. You see, there is another simple technique that we all as otolaryngologists know is type 1 Ishika thyroplasty. It is worth considering to avoid the immediate aspiration that may follow troublesome for such patient. It only takes about another 15-20 minutes. You got everything in front of you. All you need to do is put a piece of silastic or maybe a same cartilage that you had cut from the window on the thyroid and push it in. So that sort of medializes the vocal cord and avoid the most troublesome aspiration problem Kaustubh mentioned.
Thank you.
Much better.
Okay, that's great. So
Dr. Abraham, can I make just a small comment on that? Yes, two things. I agree with the thyroplasty. I think it's very useful. As Ashok mentioned, if you discover in a cancer operation that you had to cut the nerve, you can try to do the immediate end-to-end anastomosis. Usually, there is a synkinesis of the vocal cord, of the vocal fold. However, some tonus, muscular tonus, is restored, and this helps very much the phonotherapy. So what we do in a definitive paralysis is if it's paralyzed already and it won't come back, you can do either a thyroplasty, but before doing that, we do extensive phonotherapy because sometimes the contralateral normal vocal fold crosses the midline and offers a perfect phonation.
Voice compensation, right? Yeah, perfect. So that will bring. So I just want to bring in the aspect of.
Dr. Deepak.
Yes, please.
So since we are discussing the injury part of the recurrent laryngeal nerve, what you have described is the transaction injury. But as Dr. Shah had mentioned, usually it would be a crushing injury or the thermal injury while using a bipolar. So if you are using an intraoperative nerve monitoring, or if you grossly find out during surgery that you have done a thermal injury to the nerve, or you have done a crushing injury to the nerve, and you have lost the signal, or you might realize that there is a gross damage. In that situation, what to do?
Yeah, okay. So the question about a crush injury and a segment loss, I think I'll go back to Dr. Shah because he was sort of, had the idea of when you do so you would freshen the edges, Dr. Shah?
I'm sorry, what is the question?
The question is about a crush injury rather than a clean transaction.
Yeah, if most of the time, the crush injury is an accidental problem. And we say it is a crush injury, but you are rarely going to find a clamp which has crushed the nerve. It's just as you are dissecting, the nerve gets dislodged. So there is very little you can do when you lose the signal. You just make sure that all your ties that you have put on the vessels are not very close to the nerve.
Sure.
There is one tie which is next to the nerve. You may want to untie that. And either use a small electrocautery or a staple or something to avoid making sure that you're not taken the nerve in a suture. Now, I just want to make one point here. I stopped using silk in thyroidectomy. I use vicryl ties. When you come to the nerve, don't use silk. Silk will give you a permanent trauma, damage, scarring, fibrosis, which will not be undone. And many times you will feel that the nerve is okay, I'm just ligating the blood vessel, and you ligate the blood vessel, you lose the signal. You know that you're damaged the nerve. Use vicryl. Vicryl will dissolve in 3 weeks, and your nerve will get lysed, L-Y-S-E-D. So don't use silk in thyroidectomy.
Sure. Okay.
Deepak?
Yes, Dr. De Cruz?
So 2 points. One, if you are doing the 3rd division inferior thyroid ligation, by and large, we are more or less sutureless. So a point I'm trying to make, yes, once in a way you have to tie, and I agree with Dr. Shah's point that I'll also use vicryl, but try to go as close to the capsule that you really don't need a tie. Even a simple bipolar on a low setting is absolutely fine. Yeah. To answer Rajendra's question, if the nerve integrity is there, you do not have discontinuation and the signal loss is there, you have no business to transect it and put nerve. Very often the function will come back, but prevent that. When you are using your bipolar because of thermal, see that your assistant irrigates and see that your cautery settings are right. That's very, very important.
Sure.
Sometimes you have an artery forceps here. Yeah, you touch and bipolar becomes a unipolar. And the last point I want to make is all of us do recurrent laryngeal nerve monitoring, but we are doing intermittent monitoring. I think intermittent monitoring is history. The biggest injury that occurs is traction injury. When you're pulling up and you're tenting the nerve, you have the hump of the recurrent laryngeal nerve at Wang's point. And if you don't have continuous monitoring, you will come into a situation what Rajendra is describing, and you'll think it's because of thermal. It's the traction injury. So please, those of you all who swear by recurrent laryngeal nerve, trust me, if you believe it's here to stay, in 3 years' time, it will be continuous and not intermittent.
Sure. Okay.
Can I make a comment?
Yes, Dr. Sarnia.
Dr. Abraham? So actually 2 comments. First of all, if you are using, I think Dr. De Cruz is absolutely right. Unless you use continuous monitoring, which in fact is not continuous, it's continuous intermittent monitoring. you cannot abort a traction of the pole that can prevent praxis. But as we use in private practice some sealing, I like to use the ultracision, but you can use any kind of sealing device. I never use the sealing device close to the Barry's ligament, because in that particular situation, you can cause, either with a bipolar or with a sealing, a thermal injury to the nerve, not only traction. So in that particular way, I put a hemostat, a mosquito, and cut on the top of that. And another practical tip that I think is useful is that let's suppose you lost the signal. Remember, when you have air conditioning in the room, because you are under the lights, etc., the room is very cold. Sometimes if you put some warm saline in the field and leave the nerve to rest for 10, 15, 20 minutes, and sometimes I notice a recovery of the function. Even if it was loss of signal, the signal recovers. And this is a practical tip that I think is very useful.
That's very interesting. So I just like to bring in a few panelists who have not been, I must say I did not use. Rajiv, do you have any comments to make? I think you're muted.
Hello. Hello, good evening, everyone. Already all the points have already been covered in this panel. So I agree with all the panelists, whatever has been said.
Right. I'll bring you in a little later, Rajiv, when I deal with paras. So just as I've closed the session on the nerves, I'd like to bring in Aditya. Do you have any sort of questions which are outside of what is covered in the panel right now? If you want to bring those questions, we could ask them to the panelists and then move on to parathyroid.
One more question I wanted to ask. If you have an intraoperative nerve monitoring versus you don't have an intraoperative nerve monitoring, which side you would operate first, the dominant side or the normal side?
Okay, so I think I'll go with Dr. Claudio.
You're talking about the cancer, obviously. So I try always to operate on the cancer side, of course, because as I mentioned in my talk, if you are going to do thyroidectomy and you have to take the tumor out, that's why you operate on the cancer side. And you proceed to if you plan to do a total thyroidectomy, you're doing less and less total thyroidectomies these days, especially for microcarcinomas. But if you plan to go to the other side, you can go to the other side only if you have nerve monitoring, only if you have a normal signal. And there is a very inexpensive way to check for the vitality of that nerve, which is to use a nerve stimulator that costs $10. And you stimulate the nerve and you put your finger in the operative field between the two arytenoids. And if you feel a twitch there, you can be absolutely sure that that nerve is intact. For medical legal reasons, nerve monitoring offers you a record of that. But for your knowledge and for the safety of the patient, it's absolutely, it suffices if you stimulate with a very inexpensive device and you put the finger between the two arytenoids.
Okay, perfect.
Deepak, can I just add one point?
Yes, Dr. Shah.
This is just a practical, because we have faced this problem. The question that Rajendra is bringing is very interesting. First of all, you need to decide, does this patient definitely require total thyroidectomy for cancer? And if you think that he definitely requires total thyroidectomy, in the olden days, we would do the dominant side first. The nerve is intact, go on the other side and take out the other side. We never knew the functionality of the nerve. The patient did not have bilateral vocal cord palsy. We were quite happy. Everything was fine. This was before the era of using the nerve monitor. Now what happens is when there is a traction, there is a manipulation of the nerve, you lose the signal. And then there is a question, do I now ethically, can I go on the other side? And the answer is no. Your fellow is going to tell you, you cannot go because we lost the signal. So I changed my philosophy. What I do is go to the dominant side first, see how easy the dissection is. Is the nerve very close to the tumor? Is it going to be that I will be able to preserve the nerve, or there are multiple lymph nodes adherent to the nerve where you know the chances of losing the nerve signal is about 30 to 40%. Means there is an abortion rate of 30 to 40% because you're not allowed to go on the other side. And you know that the nerve is intact, but you're going to lose the functionality because of the manipulation. When I find that, I go on the other side first. Because there the risk of losing the signal is 2 to 3%. So I would do the simpler side first and then go to the difficult side, because you are using the nerve monitor and you lose the signal on the difficult side, doesn't matter because you have preserved the other side. The patient is not going to wake up with tracheostomy. Just keep that in mind, the scenario.
Sure. I think
and my approach has changed when we know that there is a 30 to 40% risk of losing the signal, not the nerve, but the signal.
Yeah. So you did mobilization, assessed the difficulty of the nerve dissection, did not do any ligations. You went to the opposite side, completed the dissection, and then came back here, making sure that the signal on the opposite side is fine. So I think that's a valid point. Now, but I'd like to just come back to the participants today. 90% of the participants today here in this panel do not have intraoperative neuromonitoring. So I'll come to Dr. De Cruz. Tell me, what would you do?
What do you do means if you don't have intraoperative nerve monitor?
Yes.
My second last side, know the anatomy well, be meticulous in your dissection, don't go searching for the nerve, let the nerve come out. Or you asking me which side to operate?
Which side to operate? Yeah, that's
which side? So I have a different philosophy from all the panelists.
Yeah.
I always operate the normal side first, because if the side is going to be difficult, I would know that pre-operatively by examination and by imaging that there's extrathyroidal spread. In that case, I'll go on to the disease side first. And the reason is the incidence of recurrent laryngeal nerve damage is 1%. We are making it look like it's 50% with the scare that I have to back out from surgery. It's too low. It's really low. I mean, I can't recollect just one patient that I operated in Guwahati in my whole career, and it was bad disease on both sides. Otherwise, I just can't recollect. And I'll tell you why I do the normal side first. I do the normal side first in difficult thyroids, because the bigger problem in difficult thyroids is parathyroid insufficiency. And if I go onto the normal side first, I know exactly where the location of the parathyroids are. Remember, there are variation, but the superior parathyroid is seen at the same position 80% of times, and the inferior in 70% of times. And I secure my parathyroids. I don't want both nerves functioning and my patient on 14 tablets of calcium getting loose motions and running to the loop. So for me, the recurrent laryngeal nerve is not so scary. I do the normal side first, secure the parathyroids, and then amidst my central compartment nodes, I'll get the parathyroids on the opposite sides. Guys, try my philosophy and y'all will thank me a couple of years from now.
Sure, thank you. So we've got two perspectives of how to approach. I'd like to just bring in Dr. De Cruz just to complete it by saying, you've done a hemi and there is a problem with the nerve on that side. What about proceeding to the other side? And what would be your suggestion to surgeons who are now listening to you?
So if I've done the normal side first and I've got a problem with the nerve?
No, if it was, for example, you've done okay, let's go the way you said, normal side first.
So I totally agree with you. If you've got what Dr. Shah and Claudio said, I'm totally with them. If you've got the normal side gone, and you're going to run the risk on the opposite side, it will be very, very unethical to give the person a bilateral cord palsy. But let me just tell you, supposing I've done the normal side and I've got an aggressive tumor on the other side that's going to run the risk of damage to the nerve, how long am I going to wait? That cancer is going to keep growing. That's a bad cancer. It's not one of these. Yeah. Go ahead.
Can I make a comment on that, Anil?
Yeah, sure.
On what you mentioned. as I mentioned, we published some guidelines of the International Nerve Monitoring Group. And there are actually two guidelines, one for initial tumors, early tumors of the thyroid gland when you are planning to do a total thyroidectomy. And the other one is on very aggressive tumors with extra thyroid extension, with gross invasion of tissues, with extensive nodal disease, et cetera, et cetera, et cetera. So these are two different. I didn't have time to touch the second guideline, but in the second guideline, the scenario is different when you present to the patients. We have recommendations on that guidelines. And one of the recommendations on the second guideline is that you have to clearly present to the patient that there is an enhanced chance of, number one, nerve injury, unilateral nerve injury anyway. And number two, and this is not a complication, this is actually a consequence. It's an expected effect of an invaded nerve that has to be taken out. But the thing is that in this situation, yes, you can have a bilateral vocal cord paralysis eventually with a trach, but you cannot, the only treatment for these patients, the effective treatment is surgery, extended surgery. So there are two different scenarios.
Yeah, okay. I think I'll wrap up the nerve.
Okay, Abraham, can I just say something?
Yeah.
Sorry, I'm just stepping back a little to the previous discussion that you have this nerve palsy, transected the nerve which you have repaired on table.
Yeah.
Two things. One is, I think throughout our discussion, we have put very little emphasis on voice therapy. That is absolutely important, whether you have repaired the nerve or not repaired the nerve. And the second thing is, I don't quite agree with Dr. Kapre, who said he will do an Ishiki type correction, even though everything is in front of you on table, because it might be an overcorrection. There's no hurry, wait post-operatively. If the patient is aspirating, then and then only you can go on and do an injection laryngoplasty, which is a bridge and gives time to the patient, improves the quality of life till the nerve recovers. So I don't agree with the Ishiki procedure at this point of time.
Sure, okay. So
Deepak, can I say?
Yes, please.
Yeah. So, Anil, I want to argue with you. The same operation which you can do first, why can't you do it second? You want to save parathyroids. Why can't you save parathyroids after resecting the right side? I mean, the tumor side. Why can't you do the same thing?
You missed the point. When you have the other side with multiple nodes, you won't find the parathyroid.
But the same side you will find. The same side you will find, right?
No, I'm just giving you a theoretical argument. If you have multiple studded central compartment on the side of disease, it's very difficult to find parathyroids. If you look at all,
I understand
prognostic, all prognostic thing, cancer, central. So you look at the location on the normal side, so it's easy to find it. Then you'll be able to secure it with 80% surety amongst nodes on the other side. I'm giving you a finer nuance of thyroid surgery. Yeah. It may not be written in books, but now in 3 years, everybody will be saying this.
Yeah, I think that's a valid point, Dr. Kostav. Just to say you've got extrathyroidal extension of extensive disease on one side, go and preserve everything on the other side. You're fresh in the operation. You're at the start of the operation. Your mind is fresh. Your hands are good. And you take care of that side, take care of both the paras and the nerve, and then come to this side and do what you need to do. And you don't have to be too worried because you've got two paras intact and you've got a nerve intact, and you won't have you won't have to do a track, and you don't have crippling hypoparathyroidism post-op.
Deepak, only thing which goes against my thinking is you have a tumor which is extrathyroidal.
Yes.
That is an aggressive tumor. Right. Now, if you are going to abandon your procedure,
right,
first doing something on one side and then going to abandon the procedure and going to delay the surgery for that aggressive cancer for another 3 months.
Yeah.
So if you are not going to abandon, you have explained the patient, then I'm fine. But if you are going to abandon the patient, then I think that's a problem.
Don't have a theoretical discussion. It is very clear. I made the point that the chances of you damaging both nerves is very, 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 very low.
So
No.
I think the point
If it
is,
was high, I would agree with your philosophy. And there is no right or wrong answer. I'm just giving you a different philosophy. You
Sure.
please do the opposite side first. I'm not going to fight with you.
no, I think we'll wrap it up to say that yes, it's important. Whichever way you're comfortable with, the patient needs to come out of it. We have the best outcome. So I think I'll wrap this up, and I think I've overshot my time. Aditya,
Deepak, I just want to.
Yeah, say.
Deepak, can I, Dr.
Yes,
Arvind, I
please.
just want to make just two quick points. One is with regards to the thermal damage. I feel that, when we are using a lot of these ultrasonic shears, there is a lot of lateral thermal damage of about 2 or 3 millimeters, and that is something that people who are using these new gadgets have to keep in mind. Unlike the bipolar, which may be pretty precise, the use of the ultrasonic shears like the harmonic focus, there would be a lateral spread of about 2 to 3 millimeters.
Yeah.
So that's where some nerve injuries can occur. The other thing is with regards to, I think, to what Dr. Lala said, I just wanted to put things in perspective. Like, for example, in the transaction injury, as you said, the philosophy should be on primary anastomosis and voice therapy. And then if it fails, or if the patient is aspirating later, maybe you can consider a thyroplasty at a subsequent point of time. Maybe that should possibly
a delayed surgical intervention.
Delayed thyroplasty. Yeah.
That's fine. Okay, I think Aditya, you would like to bring in some questions from the participants?
Not really, sir. Most have been answered along the course of the discussion. There are a lot of good questions, but the faculties have been kind enough to answer them in the chat box as well as during this. So we can probably move to the next case.
Okay, so I'll change gears and move to the next problem, which is parathyroid. And I think, as Dr. De Cruz mentioned, I think a good way to sum up parathyroid issues are: the thyroid surgery is all about parathyroid preservation. The nerves are not a problem. The moment as you become a skilled and a skilled thyroid surgeon, the thyroid is like a football. It's there. It's you're looking for the para, and you want to preserve the para. And preservation of the para is actually the key of good thyroid surgery. And here was a patient, thyrotoxicosis and with locally advanced with papillary thyroid cancer, underwent total thyroidectomy. And we are doing a study, and I really am struggling with this study in terms of ICG and fluorescence. And you know what? You have to actually strip all the tissue on the parathyroid to give them good visualization in their camera with their ICG camera. So, and I think it's actually given me a moral question. Am I causing more damage just because I need to do a study? And I think it's important to answer that question, to say, listen, I think I better not do something which is going to damage something or have a deleterious effect for the patient in terms. So this patient, the viability part of the study, which is not, so there are two aspects. There's a visualization and viability. And I don't want to go to ICG right now, but it's just to say that 3 parathyroids were auto-transplanted, and this patient had a post-operative PTH of 1.8, and we use next day PTH. So, and again, I will come back to PTH and calcium, and I understand that most people don't have PTH access, use of PTH, but here was a patient with a 7.6 calcium and symptomatic. We started on calcium and 125 dihydroxycholecalciferol. And so post-operative day 2, you can see that the calcium did not come up. It was also, so I'll just bring in a point and I'll come back to the discussion later. And we check magnesium on day 2 when your calciums are not picking up after adequate oral supplementation. You would do a magnesium, and if your magnesium is less than 1.6, which is the cutoff, you would say, give your magnesium infusion, and then you will get your calciums come up. And this happened in this patient too. And slowly, with the replacement of the magnesium, the calcium then picked up, and then we could send the patient home on calcitriol or calcium carbonate. So this is how we managed, but I would like to come back to the question of prevention and then come to therapeutics of calcium supplementation. So I come back to the speaker, Dr. De Cruz, you started today, and just to sum up, as you said, superior parathyroids constant in position, inferiors are more varying, stick to the capsule, and you will see the parathyroids in terms of that one rule of one which you said.
You know what? I would make comments again, but it will be a repetition. I think many of the panelists have not spoken. Maybe you should give them a chance.
Sure.
Arvind,
Sure. I think I'll go to Rajiv.
I'm getting some messages that why don't you shut up and give others a chance?
Sure. Okay, Rajiv. What are your tips and tricks to tell people how would you preserve the paras? And I'll come to Sajid next.
Anatomical details and very meticulous technique to identify and preserve the parathyroid. And if you have any doubt during surgery that gland is parathyroid gland is confused or like devascularized at that point of time, it should be just confirm that it's parathyroid tissue and it should be transplant.
Okay, I think we have an issue with his internet because it was breaking up and I didn't really hear him. It's possibly his bandwidth is down. But I'll come to Sajid and then see if I can get back to...
Sir, I think my point is, we really do not have an answer. I also have faced this problem. If somebody says that I should have no hypocalcemia postoperatively, I am sure I will not be able to guarantee it. Because we still do not know, there are lots of points which we do not know. But if that is why I'm sure, Dr. Deepak, you are also studying on ICG. So we still do not know whether one parathyroid preservation is good enough, two is good enough, whether all parathyroid needs to be dissected. But the points which Anil Dikru has said clearly, how to identify these parathyroids is what we have to follow. And if we can preserve as much as parathyroids, that is the best. But still, we may have problems post-operatively. So
I think the point taken, Sajid, but I think the point is we should aim to save all four paras.
All parathyroids.
That is the point. I mean, rest of it, whether you're able to do 2, 3, or is secondary. But the point is try to get all four paras intact.
We have been practicing stepping down of administration. Again, Anil Dikru had told 2 methods of treating hyperparathyroidism. But after we started treating, giving an additional, like stepping down of calcium supplements, we have had no patients coming back with symptomatic, because all these thyroid patients, we will be discharging at 2nd, 3rd day or 4th day. But most of the time we used to have patients coming back with hypocalcemic symptoms at the end of a week or 10th day. So that has not happened after we started. Like we used to give supplementation with IV calcium, start with a higher dose of calcium supplementation. And then if the values comes to normal, we would step down and then go. After we started this, we had not problems.
So did you say that you are doing routine IV supplementation, even if asymptomatic?
Yes. If the patient's values, yes, we correct the biochemical. It is not the blood values are normal, we do not give. But even if the patient is asymptomatic, the blood value shows less value, we would supplement IV and also start with calcium and calcitriol, and then step down as we go on. Because earlier, when we were not practicing this, we used to have lots of patients coming back, because all these patients will be discharged in 2nd, 3rd day, and they come back on the 7th or 10th day with symptoms. So that is what, and the symptoms are not simple.
Sure. Okay, I'll just bring in the aspect of vitamin D, and I'll bring in Murad here. And how would you approach a patient?
So I think, yes, we have a different approach at Hinduja Hospital. And I think the first step is the preoperative management. First of all our patients preoperatively will have a serum calcium, will have a vitamin D3, will have a magnesium and a phosphorus evaluation. Having said that, all our patients routinely, preoperatively, the first day they come into the OPD are started out on vitamin D3, 1,000 international units per week, as well as calcium supplementation. Because if you look at all the data in the literature for Indian patients, or the prevalence of vitamin D3 deficiency in our society is as high as 60 to 90%. So prophylactically, we start vitamin D3 and calcium for all our patients. Then we go on for surgery. And later on, we can discuss when the discussion is there on the intraoperative PTH. That's also what we are doing. But we've noticed that a lot of our patients with this SOP that we follow, a lot of our patients will have biochemical hypocalcemia, but not be symptomatic.
Okay, so I thought that comment about actually giving also calcium along with your vitamin D preoperatively is something new, but vitamin D, Dr. Shaha mentioned that. Dr. Shaha, do you replace or supplement all your patients with vitamin D before you operate?
We do the vitamin D levels.
Yeah, if
the
low?
normal is about 30. If they're low, we supplement them right away.
Before you operate?
Yeah.
And you look for a normal value before you operate?
No, we don't.
We don't. Right.
And we definitely don't give calcium extra.
Yes, that's a point. I think I'd like to defer with.
Maybe something that we may want to study, but we don't have any data on that.
Right. I mean, I don't think by the endocrinologists support that from our perspective. We say we replace vitamin D. We don't recheck to say, okay, unless it's normal, we're not going to operate. But you would, for the time period, for the run up to the operation, you would give them vitamin D and then go ahead with the operation.
Yeah, Deepak, we do not stop. I mean, we do not wait for the levels to come to normal. Sure. I'm just saying that during the workup, while they come in for surgery, they receive this. And anyways, all your patients are getting calcium. Yeah. It's one of the recommendations for, all postmenopausal women plus elderly people. So why not start preoperatively calcium for these patients as well? And we found that symptomatic hypocalcemia has been well under control with this regime.
Okay. Rajiv, would you like to comment? I'll just hear you out and then see, because I think your internet was unstable at that point of time.
Yeah, generally what we have protocol in the post-op that we start, we do serum PTH level on day 1. And if calcium, we start with oral calcium 500 3 times a day with Rocaltrol activated vitamin D3. And all these patients, and we see the trends of 2 calcium on day 1 and day 2. And if it is rising, we discharge these patients. Sure. And all these patients have done well. Hello?
Yes, please carry on.
Yeah, so all our patients have done well with this regimen. So IV calcium, hardly 1% or 2% patients required IV calcium in the post-op. But most of these patients have been managed with oral calcium and Rocaltrol.
So I just changed track and say, before you go to the post-op, I'm asking for the intra-op steps you take for your preservation of your parathyroids, and what would you do?
Intra-op, what Dr. De Cruz has mentioned in his talk, very meticulous dissections as well as anatomical details of all these glands that play a very important role in preserving vascularized parathyroids.
Yeah, okay.
So if you have any doubts, do auto-transplantation of these glands. If any devascularized or any contusion of these glands are there. But so at least make sure that at least I make sure that 2 parathyroid glands should be vascular.
Okay, I think Sajid was having his hand up. Did he have a point to make?
No, I think that was the same point which he has mentioned.
Sure, okay, fine. So I just want to show you this picture. This is you can see the para is, we've just ligated the vessel which was going into the thyroid, distal to it. And you see the para, and the next picture shows that this parathyroid became dusky. You can see that this is the inferior para and this is the superior para, and this has become dusky. And I just like to actually show that picture where we use the knife test. And so Dr. De Cruz, more cultured way of doing the prick test is this, and that was using the 15-blade knife to actually make an incision on the capsule of the gland and let out the hematoma, which is actually a subcapsular congestion because you've ligated the distal outflow. And the color of the parathyroid actually got better. And you can see these are the 2 paras after that capsular, that incision. And you can see that I didn't do an auto transplant here, and both these paras were intact. And that's the nerve which is there. So I just like to comment on that you look for viability. Forget ICG. Let's not discuss ICG because I don't think we'll end up here. We'll end our conversation. But I think looking for preserving the vascularity doing a good dissection. Don't use thermal devices close to the para. And definitely what I have started using is I use a 2 mm ligger clip when I ligate the vessel. This was in 2017, this picture. From 2000, I changed over the last 2 years to actually change to using ligger clips onto para and then drop it down. And I love that point which Dr. De Cruz said. That gives me my landmark to say, this is my ligger clip on my para. When I do a neck dissection, I make sure that my para is still intact. Otherwise, it will go into the bucket along with the lymph nodes. Yeah.
Deepak,
Yes.
Yeah, Deepak, one comment, please.
Yes, please, Rajiv.
Yeah. So, like with this knife test, you have to make sure that this gland, because immediately after putting the knife on the capsule, that vascularity improves in these glands. But after sometimes, again, you have to check, maybe after 10 or 15 minutes, that this gland is again not getting.
The point taken, Rajiv, that this is at the end of the operation. So when I'm closing, after the knife test, which was done like about half an hour or 1 hour prior to this. So this was then, you found that this vascularity was acceptable, and I went ahead and closed without actually transplanting this patient. Yes, please.
My one point, if we use a loop or some people use microscope, the small vessels going into the parathyroids can be identified, and that gives a lot of advantage.
Okay. So I'll just bring in Dr. Shah to wrap up the comments about anything more you would like to add.
Well, nothing more. I think I think you made a comment, but you didn't expand on that. We should change the name of total thyroidectomy. We should call it cervical exploration and preservation of parathyroid.
Parathyroid, yeah.
I think there are two things when you are attending or whatever practice. You think more about the nerve. You think more about the parathyroid. You will have less complications. Think about parathyroid every minute. Start from the upper pole. Preserve and keep in mind, every parathyroid is the last parathyroid.
Yeah.
If you keep that mentality, you will try to preserve all the parathyroids.
That's a great philosophy. Yeah.
God forbid you damage the parathyroid or it is getting black, then auto-transplant it. Yeah. In a patient with proven thyroid cancer, don't auto-transplant unless you get a frozen section.
Yeah.
Because the worst thing you do is auto-transplant metastatic thyroid cancer.
Sure.
And these are the important points. Just keep thinking about it. Where there has been extensive dissection, monitor the patient carefully post-operatively.
Yeah, and I'll bring that point which came up in the talk is about saving the inadvertently excised parathyroid sitting subcapsularly. And, a point of actually turning the gland around and putting it on, as Dr. Sernia mentioned, while still sterile, and cutting the capsule and looking for the para. And if there is, you may have to send us frozen to confirm it and then auto-transplant it. And I just come to auto-transplantation. How would you do it, Dr. Sernia? Was it the injection, or would you just put it into the muscle?
No, I do it exactly the same technique we do auto-transplant a parathyroid gland in hyperparathyroidism. We mince it and we do a pocket. It doesn't have to be in a pocket in the forearm, but it can be in the sternomastoid muscle, for instance. And it works. We do only one pocket, blunt dissection, and just a non-absorbable suture for you to localize if needed in hyperparathyroidism.
Anybody else using the injection technique?
Sometimes.
Yeah, okay. Dr. Kapre? I'll come to you, Arvind, in a
minute. I use the injection technique, but I don't make a pocket. I inject it. Because by making a pocket, you're creating a coffin with a blood clot around it, and that blood clot will form and fibrosis, and your parathyroids which are injected will be like 5 feet down the earth and soil on the top. So inject rather than make a pocket. That's my question.
So Arvind, you had a point quickly?
No, it's exactly, I think, what Dr. De Cruz had mentioned, that the moment I diagnose or I intraoperatively that this is going to be a dusky gland, the next moment I take it out, even though I may not have taken the specimen out, but at that time intraoperatively, the moment I diagnose that is going to, it's a non-viable gland, I immediately take it out and auto-transplant it. So rather than sort of do it after the lobe is out or at the end of the surgery.
Okay.
The other thing is about at the end of the surgery, I have used ICG in a couple of patients. But what is it is at the end of the surgery, if you use the probe, you see it nicely fluorescence. So I don't know, of course, I've not had that much experience, but maybe at the end of the surgery, just like a nerve monitor for the recurrent laryngeal nerve, maybe the ICG fluorescence on the parathyroid could be an indicator of a viability of the parathyroid. But it's very early days for me because I've just used it in just a couple of patients in a demo ICG monitor.
Yeah, okay. I just to bring this picture to show a good way to say parathyroid will not float, which will sink in the syringe, at the bottom. And you then know that you've got parathyroid tissue. And all you need is about 1 ml of saline. And you could use it with the hub of a needle, you take off the needle and just use the hub. And then that would be used to inject into the muscle, into the right. This is what I do. And this is basically an injection technique rather than actually mincing and putting it into a pocket. But that's 2 ways to skin a cat. And I think I'll just leave it to people to choose their personal preference. Any other comment?
Deepak, one thing which I would like to mention for the trainees is that it is very important not to keep that parathyroid, which part of which you have sent for frozen, drying up on your trolley. It has to be kept in the saline, in the ball of saline, and preferably if that saline is cold, it will a little bit harden the parathyroid so that it will be easier for you to mince it at a later one.
No, absolutely. I think it's got to be cold saline. It is not warm saline which cooled, because normally the operating nurse would give you warm saline, because that's what, at least in my institution, it's warm saline for wash. But you should not, I go to ask them to open a separate 100 ml cold saline and then use that to put it in a bowl and keep it there while you wait for your frozen report, or you're doing your auto transplantation a little later. So I think point well taken. Not only should it be cold, it should not be warm, which has become cooled, because that also adds on to a damage to the gland. Okay, and I'll just come back to, okay, I think I'll skip patient 4. Any other comments on parathyroid disease while I just move this on?
Just one point about the ICG.
Yeah.
The whole issue about ICG is you have to have an absolute bloodless field, because the moment there is some oozing of blood, your ICG comes out along with that.
And not only that, Murad, it's actually, see, when you normally do a parathyroid thyroid surgery and you mobilize the paras and you've left it along with the fascia on top, still the vision is not very good. It's not the bleeding. It's just that the fascia on top does not give you the good picture which they want for the visibility, So the camera then says, take off the tissue from the top of the para for them to see better. And that to me is causing problems when I'm having patients who are dropping their calcium, just because I've stripped the surface of the para. Okay, I'll come to supplementation, which I think is very important. Just I put costs here. People will relate to that from India at least. So preserving parathyroid is very, very crucial, because the cost to this patient is huge. And most of our patients are doing out-of-pocket expenses. And those of you who are treating maybe the upper class, but majority of us are treating people who live on a hand-to-mouth existence. And I think just to see this cost would tell us to say, please make sure that you are preserving your parathyroids and not causing more harm to the patient. But still, as you do it, you may still have a patient like this. He's our patient who's got hypocalcemic Trousseau sign. You need to see that how do you manage these patients? And anybody wants to comment? Or Dr. Sarnia, how do you manage a post-op patient like this who's got tetany?
Well, this patient obviously needs IV calcium. We use 10% calcium gluconate in 250 or 500 cc of glucose saline or glucose serum, and we keep it in continuously infusion. Yeah. Yeah. And with control, very tight control, and at the same time, patient permitting, the symptoms permitting, we supplement orally. We try to start as soon as possible the oral supplementation. Usually when you have this very, very symptomatic scenario, in about 24 to 48 hours, it's enough to supplement it orally. And I call attention, especially for the younger people in the audience, of one particular issue. Female patients, and usually athletes, female athletes, they are very muscular. And so in this kind of scenario, they have very important symptoms, eventually tetany. I had a patient who had opistotomus. She was arched like that. And so the two worst hypocalcemic crises that I had were two young women, the two of them professional athletes, after an extensive operation like that. They came to normal. It was temporary hypoparathyroidism, but it was extremely symptomatic.
Sure. Okay. Dr. Shah, any comments on how would you manage this patient?
Just one point. This is a serious situation.
Yeah.
And this makes you the most humbling surgeon.
Yeah.
I think thyroid surgery is one surgery where the complications of thyroid surgery are much worse than the disease.
Yeah.
You know, you do the hernia, there is a complication. It is not a problem. You can get the patient out of it. But the nerve injury and the parathyroid problem will make you humble for the rest of your life. The complications are more distressing to the patient. And believe me, they are worse to the surgeon.
Yeah.
So just keep that in mind. This patient cannot go home, needs to be in the hospital, carefully monitored. And just keep in mind, the people with TROSA and Schwostek signs are at higher risk for tetany. And people with tetany can have airway problem. So monitor these patients very carefully in the step-down unit or in the ICU. So with the cardiac monitoring to make sure they don't have major cardiac issue along with your hypocalcemia.
Sure. So I think this is a crucial, this is a very important point you made, Dr. Shah. And I think this is very, very humbling. And I think as surgeons, it's good to have a little bit of humility. And you get a knock on your head occasionally when you have this, just to bring you back down to earth. So look at it as a thing to bounce back and to do well. And so I just like to say, I just leave this slide with you to show, you could take it or leave it. We use PTH as our guide, but I'm conscious of the fact that majority of the country, the surgeons don't have access to PTH. If you send a PTH, your result is going to come back in 2 days. That doesn't make any sense. And so we use a next day PTH. And I just like to bring in the calcium infusion, which is running at about 1 to 1.5 milligrams per kilogram per body weight. So that is about 100, 10 ampules of calcium gluconate in 1,000 mils. And you run it over 10 hours, you'll get your point. So that will just give you your infusion, and you run it in 2 sets. So by next day morning, you would have finished a full 2 sets of infusion, and you check your calcium, not immediately, but check it after 12 hours, because you'll have a falsely high value immediately. And so then continue your infusion, have a break, check your calcium, then you can change on to oral calcium. And if your symptoms are better, you can start tapering down your calcium roughly over 3 months. So we would go about 6 grams or 8 grams of calcium carbonate, along with 0.5 micrograms of 125 dihydroxycholecalciferol twice a day. That means you would given about 1 microgram, and then you start tapering over a period of time, and that is as the symptoms go. And I think for want of time, I won't really push too much on discussion. Is anybody wanting to make a very pressing comment? Dr. De Cruz, I know you've been silent because somebody messaged you and said, shut up, but I want you to open up now. He's gone off, is it? I think he's disappeared. Hello, Dr. De Cruz, are you there?
Yes, I am. Tell me.
Your camera is somewhere up in the roof, so I don't see you.
You see, at my age, after sunset, and if I was in Gujarat, we would have been doing something else. And Costa knows that. He should have told you.
Yeah. Also, you're having your swig at the bottom.
Go ahead.
Okay, fine. Yeah.
Tell me.
So I just wanted to know, would you have any really pressing comments about post-op calcium management?
Nothing really. I mean, everything you all have said, you've covered the drip. Claudio made some great comments. The only thing is between calcium gluconate and chloride, when you give the infusion, we prefer gluconate because it causes less thrombophlebitis is kinder, but sometimes the bioavailability, if I could use that word, is better with the chloride solution, but then you need to be scared of your thrombophlebitis. But I think everything else has been covered. Look at magnesium as well. I think you made that point, and look at your vitamin D. So these are the only things that I would say.
Right.
And also, when you give the calcium, it depends on which elemental calcium you're giving. Some need an acidic medium, some need to be taken with food. And I don't want to get too theoretical here on those kind of discussions.
So, tips to say calcium carbonate, you should not give an antacid or a PPI along with that. Just avoid that, because otherwise your calcium absorption, which takes place in the stomach, does not happen. So I think we'll move on. Aditya, how are we for time? I know that you may be really hard pressed. Shall we stop?
Listen, Kostov, you better do Swiggies and send us dinner now if you're going on and on, huh? Please.
Sir,
at least for the panelists.
At least those in Ahmedabad with him have definitely told him to do that, sir. So.
Yeah. Dr. Shah also will get something in New York. You have to tell Musha. Listen, it's like
Anil, why do you pick on me?
It's like 3 hours. Deepak.
Yeah.
Say that again.
No, he's asking why you're picking on him all the time. He's got the New York mentality now.
I love it because you raise the bar. You'll stimulate everybody. Otherwise, it'll be dull.
Yeah, sure.
I'm always scared of
Dr. Abraham.
Audio.
Yes, Dr. Sanya, please.
Yes, I'd like to make just one quick point on the treatment of this hypoparathyroidism, and one other point about a question that was not answered, and I think we should bring that. I have to start orally the oral administration of calcium and the Rocotrol together, because when you do it intravenously, you do it only with calcium. And at least in our experience, when you start the oral replacement, it's pointless to give just calcium. You have to give Rocotrol together with calcium. It enhances the absorption.
Absolutely.
And the scenario when you have hypoparathyroidism after Graves' disease is more serious, because you can have a hypocalcemia also because of the hungry bones that can withdraw, not only in hyperparathyroidism, but also in hyperthyroidism. So I think it's a different scenario.
Dr. Sanya, that was my previous patient. So I skipped that patient. It was primarily from Graves and hungry bones. And, you know, that patient stayed in the ward 15 days. And I know that I'm talking to oncosurgeons who may not be seeing these patients. So that's why I've kept them out of the book. But actually, they are much more difficult to handle. The patients who've got hungry bones, and you operate on Graves or Graves with thyroiditis, is the most difficult operation, not cancer. And I think,
so let me just make a quick comment on a question that I saw in the question and answers that was not addressed. One of the participants asked about if I use, because he noticed that I used the ultracision. If I use the ultracision in a COVID scenario like now, and I think this is a very, very important question for the present times. If you allow me to just make a quick comment on that, I think that the contamination, when we operate COVID patients, COVID positive patients, for everything, obviously everyone has to be protected, and the whole personnel, etc. But the issue of viral load in the vaporizing tissue in a thyroidectomy, for instance, is not as important as the virus load that it is in a tracheostomy, or even in an intubation at the induction of anesthesia. So I think these are the crucial moments if you are operating an oral cancer or larynx cancer, or even a thyroidectomy during the intubation. That's the dangerous part. So you operate under negative pressure, obviously personal protective items for everybody, circulating nurses, anesthesiologists, etc., scrub nurses. But I don't think this is such a critical issue like when you open the aerodigestive tract because of the viral load.
Yeah. I think, thank you for that comment, Dr. Sania, with regard to current times. And it's very important for people to know how to handle COVID and thyroid surgery. Yes, Dr. Costa. Yes.
Yeah, Deepak, actually the Swiggies and Zomatos are going to be at the doorsteps of all faculties within next 10 minutes.
10 minutes.
So we have 10 minutes.
So, okay.
So you have time to take one more case, sir. I think
I can
allow that much.
I just like to bring in people on comments on approach to a hematoma. And what would you do? Do all patients need to be explored? How would you go about it? I'll come to Dr. Let's go to, I think, Murad, what would you say?
Yeah, so it depends when you have picked up this hematoma. In all probability, I mean, the most common time for the post-operative bleeding, first of all, we never put a bandage like this.
Yeah.
All my wounds are kept open. They're not strapped like this anymore. And in case somebody does have a hematoma, as I said, it's either during extubation or in the recovery room. So that's when you have to be very alert and not just looking at the neck, but looking at the drain, because your first sight is with a gush into the drain. But again, many times because of that big gush, the drain gets blocked because of a clot, and then it starts swelling up.
Yeah.
So if the patient is in the recovery, straight back into theater, and I would open up the wound and drain the hematoma.
Right.
In case it's a gradual sort of thing later on, then maybe in very select cases, a conservative management.
So I'll tell you how the situation is. We don't strap the neck too. All patients have just a small plaster, or these what we call as padded tegaderms. But when you have a full drain coming in the post-op period, no clots, neck flat, then strap and leave this patient monitored very carefully with this drain volumes being monitored. That will tell you there's a subset of patients who have a hematoma, which possibly can be managed conservatively and don't have to operate everybody. And that shows up even in my data when I presented my complications, that we had 7 patients out of our 600 who had bleed, but only 4 went to the theater. And this patient, now the one previously went to the picture in the case which I showed, went to theater because of an ITA bleed. But often it's not ITA which is a problem. It's usually a muscular branch sitting in the sternomastoid, in the muscle, which can cause you this problem and you have a hematoma. So, and I think it's important to understand that there's a small subset you can actually look for managing conservatively when there's no respiratory.
That is the one that when they are sort of being extubated, the BP shoots up, it suddenly goes to 180 systolic or 200 systolic. Sure. That's the time you have a gush of blood, but you just sort of let them calm down, just keep them observing them on the operation table. As the BP comes down, this will sort of settle down.
Another point is actually during extubation when they cough.
Yes.
That could be the cause for your bleed to happen.
So yes, can I make a comment?
Yeah.
My comment is that as we have younger people in the audience, that it's better to prevent a hematoma instead of treating it. And one thing that has been addressed, that hasn't been addressed, but it has to be addressed when you see the patient for the first time before the operation, is number one, to actively inquire him or her about aspirin, which is very common these days. I don't know in India, but in Brazil, it's very common. In the States, I'm sure it's common. And ginkgo biloba, ginseng. These two, it's very common. And the patients don't think this is a medicine. They say, oh, it's natural. So you have to actively inquire the patient about that. Otherwise, you may get in trouble.
So I think I'll step one step backwards to say, intraoperatively, when you close, would a Valsalva help? Would you ask the patient to, ask the anesthetist to close the valve and give a bag to see if there's a bleed? Would you do that? Costa, would you like to make a comment on that?
So all patients, we do Valsalva, as well as what we do is giving a Trendelenburg position and ask the nurse to press the abdomen. We want to actually increase the intrathoracic pressure and see that there are some small venules which can bleed post-operatively, which are really ligated well. It's not more for the arterial, it is more for the venous bleed.
Venous ooze. Okay, fine. So using a Valsalva, getting your hemostasis sorted out before you close, and then making sure that you don't have a bleed is more important. Your bleed rate should be around 1%.
Listen, Deepak.
Yeah, please come in.
So while I again agree theoretically with Kaustubh and you, let's not make thyroid surgery. We are not in the Samuel Gross era. I just want to tell you that if you've done a hemithyroidectomy, you've used 1.5 gauze pieces at the most in your surgery, which is the rule. I mean, you're not going to put in Valsalvas and get the nurse jumping on someone's belly to make sure of a venule. I can
So
understand if it's a big multinodular grade.
I think Dr. Kaustubh, he's had his drink. He's had his drink, so he's in good spirits. Okay.
No, because because Kaustubh would tell me about
Anil, with private practice, you must be having those small hemithyroids.
No. Yeah. No, but I think the point here, Dr. De Cruz, is that for young surgeons, when they close, if you have a protocol in place, it gives them peace of mind. Okay, I've taken some steps to ensure that my preventive measures are taken. It can still bleed even after that.
Okay, so I'll make my other point. The point that will bleed in a small thyroid are the terminal branches to the inferior thyroid artery.
Yeah.
And that is very tricky when you go and explore with a small hematoma, because these youngsters then try to evacuate the hematoma in a hurry. They'll avulse the little parathyroid that's on its slender stalk, and they might even damage the recurrent laryngeal nerve.
Sure.
So my teaching in a small thyroid is evacuate very, very safely. If it's a large thyroid, be careful, have everything in position, because the gush of blood will be tremendous. But in a small thyroid, keep irrigating the wound and gently sucking out from the surface, as well as lifting the clots very gently, so that you can see the structures before you see the bleeder. That is my teaching to the youngsters.
Yeah, okay, point well taken. And I think for paucity of time, I'll move to one more complication, which is chyle leak. And most of chyle leaks usually are managed conservatively. But when you have a persistent lymphatic leak, and this we had on the right side, which I was thinking will settle down 200 mils per day, and I had to go back into this patient, I think on day 10, and we had found a leak in the postero-inferior aspect of the right IJV, possibly a large right lymphatic chain. Okay, but before that, just to say, apart from chyle leak managed conservatively, which is most of the cases, you may have to go into the neck, mainly on the left side. But I'd like to just show another patient. Okay, this is a this is a lawyer from Bangladesh who's no more alive, sadly, because of progressive medullary thyroid cancer. He had a lymphatic leak, and you look at that suction drain at the back. This was the volumes which came out of his neck every day from a left MRND, left selective neck dissection. And this guy, we had to manage obviously with going back into the neck and ligating that and putting even a patch of omohyoid muscle to close that leak.
May I make a comment?
Yes, please.
We published about 10 years ago a paper in the head and neck on a maneuver to do intraoperatively before closing the patient, where a central compartment neck dissection, or especially a lateral left neck dissection is done, which is called abdominal compression. And this, in my opinion, is the only way to detect intraoperatively a chyle leak, and then you can solve it at the moment with no need for reoperation.
So
we don't have time to elaborate on that.
Yes, I think that point is well taken, but even a Valsalva works well, Dr. Cernia, in terms of actually...
Not in our experience, because of Valsalva, and I demonstrated that. Address the paper, you'll see that. 4 years ago, I presented that in the IFNOS World Tour. I don't know if you remember that. Because the Valsalva actually collapses the thoracic duct. Contrary to the abdominal compression, you detach the ventilation tube, then you ask the anesthesiology to do that, and then you make the compression, and then you highlight, you can enhance the pressure inside the thoracic duct.
Okay.
So
Fine.
I strongly advise you to try that.
Sure.
Deepak, I just
Yes.
want to make a
Deepak,
comment.
Deepak, I just
I
want to
think
make
I
a
just
couple
had
of
somebody
points.
who asked a question before I come to Arvind.
Yeah.
Who was saying something? Okay, Arvind, please. Dr. Shah, you said something.
Yeah,
Yes,
I
please.
just want to make a comment because we had unfortunate series of chylothorax and chyle leaks, and they can be very distressing.
Yeah.
Not only they are distressing, but when we talk about post-operative major disasters, this is one of those. And it does occur with, I don't have any data, and I don't think anybody has done the analysis, but it is more common in medullary cancer, especially because a bulk of the medullary cancer metastatic disease at level 4, 5, 6, and 7. And as you are taking out the superior mediastinal lymph nodes, the lymphatics just leak out. So two things. We have recently practiced on 6 patients at Memorial embolization, thoracic duct embolization. Our interventional radiologists are very good, and they can do a good job. And believe me, we published this recently. It is under my name. You will find it easily. In all the 6 patients, we were able to control the chyle leak within 24 hours.
Okay.
So there is something. The second thing is, in this patient with medullary cancer, you went in the neck and tried to find the bleed, chyle leak, etc. It may be very arduous task. And if your thoracic surgeons are good, especially with a video thoracoscopy, they can do the ligation of the thoracic duct intrathoracic. So you need an expert thoracic surgeon who has a lot of experience with video thoracoscopic procedure, dissecting the mediastinum, finding the thoracic duct, and put a clip on that.
Sure.
And let me other choices. If you explore, you did it.
Let me respond to this. I agree with both.
Go ahead.
Yeah, I just wanted to the morbidity, the cost, the expertise required to clip it in the neck is easier than to do the other 2 procedures. Yes, it's described, and we would do the same at the Tata Memorial when I was there as well. But again, for youngsters, the moment you see a chyle leak, if it's a high output leak, get in quickly into the neck before the area becomes very mucky and you won't be able to locate the thoracic duct and clip it. It's the only structure that comes from medial to lateral behind the carotid artery. See the trunk, lig it in continuity with the colored suture so that it can be seen like the silk which we were talking about, and you will be good 9 times out of 10. Dr. Shah's suggestions are absolutely correct, but those are really the troubleshooting type of ones that you can't get in the neck. So I would endorse both, but if you can get it in the neck, I would say go neck.
Yeah, okay, fine. Dr. Arvind, you want to say something, Arvind?
No, exactly the similar points. But the one thing about prevention is these are the patients in whom after surgery you do a head down and a Valsalva. So quite often you would sort of pick lymphatic leaks rather than hemorrhages, I think, and try to sort of, and exactly as Dr. Dikru said, triage your patients. Very high lymphatic leaks, immediately go in for surgery through the neck. Then the fields are really good. You'll be able to salvage them. If, like the scenario you said that there is a chylothorax, of course, there is a thoracoscopic maneuver in which you can clip this. But I've also seen good interventional radiologists, exactly as Professor Shah said, that who are able to sort of, put nice gel foams and some coils, and they are able to seal the even large lymphatic leaks also they are able to seal. So it all depends upon how much expertise you have at your particular center. And the chylothoraxes are ones that are really distressing and should be sort of managed by a video assisted thoracoscopic approach if you don't have a good interventional radiologist near you.
Sure. Okay. So I think I'm trying to wrap up. Yes, Dr. Costa, tell me.
Yeah, one small point what Anil said, I wanted to elaborate a bit. The important thing in ligating the thoracic duct in the neck, especially in an inflamed area, you have to be extremely careful and clearly identify the vagus nerve. And of course, carotid is quite large, but vagus nerve, if you're clamp or if you are going to do a suturing with the needle, you might ligate the vagus nerve there. So you have to be extremely careful in that area when you are trying to ligate it.
Sure. Okay. So I think when we had, I'll just say how we managed this patient who had a chylothorax on post-op day 6 was we actually did VATS. We did a video-assisted thoracoscopic ligation with the upper GI surgeons, and we clipped the thoracic duct as shown here. And it was dramatic. It was next day it stopped. It was like 1,500 mils in the chest tube, and we could pull out the chest tube in a couple of days, and we discharged the patient. So there are two non-cervical approaches: thoracoscopic ligation, like clipping, like what we did using the upper GI surgeon's help, or using the radiologist to do embolization. And I think I'll close with that because we really run out of time. So again, I'll say, any closing comments by Dr. Costa? Would you like to say something?
Only one sentence in your, excellent quotes. The complications are God's way to make surgeons humble.
Oh, that's my next slide. That's my next slide. You took my thunder away. Yeah.
Sorry.
So that's my next slide. Better is possible. It does not take a genius. It takes diligence. It takes moral clarity. It takes ingenuity. And above all, it takes a willingness to try. And above all, you need humility. And I think it's a knock on our heads and a rap on our knuckles, so to speak, just to say, listen, boss, you're human. And you need to continue to learn from what you make mistakes. And I learned one more thing, and I think that's a philosophy. Stick close to the patients who you had a complication with. You tell them that, you stick close to them in terms of being with them through that problem. And they will realize that you stand with them in spite of all the problems. You don't want to run away from them. You want to run to them. And I think it's important as a surgeon to actually run to them. And you will learn that you become the best friends. You're no more a doctor patient, you become a friend, because then these guys say, you stood by me when I was down, and when I'm out, you actually pulled me back up. And I think that's very important. Now with that, I'll close, and thanks Aditya for giving me this opportunity. And I bring greetings to you from Velo, and I'd like to welcome you next time to come to post-COVID era to come to Velo. Thanks.
Absolutely. Thanks very much. I'm overwhelmed beyond words for the amazing panel discussion that we've had for the last whatever time that we've had. I don't yet remember what time it was. But thanks so much for the wonderful academic feast to all the faculties who so enthusiastically participated in this. It was a wonderful occasion to see so many national and international faculties come together on a platform and conduct such a wonderfully civilized debate where everybody made a great point and it was internalized by all us aspiring surgeons for the future date. And I can say this for all the trainees that have been listening to this, that every trainee now has become a little more fearless and a little more calculated in the way they deal with thyroid surgeries. Thanks very much again, and hope to see you next time.
My apologies if I didn't utilize all panelists to the best possible time, but I think I had too many cases and I had to drive home the points. Thank you once again, Kaustubh, and thank you to the team at Ahmedabad. And thank you to Dr. Sarnia and Dr. Ashok Saha to add to the value and the richness of this whole debate.
Thank you. Enjoyed it very much.
We're all blessed. Thank you. Thank you, sir.
Thank you.
Me too.
Okay.
Thank you all.
Be well. Take care.
Bye. Take care.
Claudio, be good.
Yeah. Please mask up.